Honor and pleasure to present Professor John Sepp. Professor John Sepp is a professor of medicine at Dalhousie University. He's attending electrophysiologist at the QE2 Health Science Center, Halifax, Nova Scotia. Professor Sepp is Assistant Dean of Clinical Research at Dalhousie University. He is a world-renowned figure in electrophysiology and particularly in ventricular tachycardia. He has over 200 publications in the field, and he holds several patents, among which the needle ablation that we will talk about today. And overall, he's my mentor, and I'm happy and honored to welcome him virtually in Egypt and welcome him to the arrhythmia camp. John, can you hear us?
Ahmed, thank you very much. Thank you so much for the invitation and the opportunity to join you, even though not in person. I'm hoping somebody will let me know if the audio is not working okay. Are you able to see my screen?
Not the screen, not right now, but we can, yes, we can see your screen right now, and we can hear you quite clearly.
Excellent, thank you very much. I'll just start with, here are my disclosures. And I am coming to you from across the ocean. I've had the pleasure of visiting a couple of times and hopefully again someday soon. Today I wanted to talk a bit about the intersection between anatomy and physiology. You know, 25 or 30 years ago, well, let's go even farther back. Cardiac electrophysiology as a specialty started out as a physiology specialty. And then once we got catheters and then 3D mapping, we morphed from just being physiologists to being anatomists. And probably we should change the name to cardiac, I don't know, electrophysiological anatomy or something like that, because anatomy has become critically important to what we do. Let's get right into it and talk about ventricular tachycardia. I know you've already talked about mappable VT. We'll move through this fairly quickly. The thing about mappable VT is it's not very common anymore. We are now treating people earlier in their course before their VT is dramatically slowed down on amiodarone, and treating VTs beyond the initially inducible one or the one that presents clinically to improve long-term outcomes. So for VT to be mappable, it needs to be not only hemodynamically tolerated, but metabolically tolerated. So enough cardiac output that the patient doesn't eventually get sick. And the approach to this is two things: to know where the scar is, and then to be able to determine, so know the scar, and second, know the myocardium. So the myocardium is what generates the ECG, and the scar is what generates the VT. And so if you could just do it perfectly every time you'd induce VT, know where it's exiting the scar, and then just explore the scar proximal to that and find a vulnerable channel and ablate it. So in mappable VT, your targets in order. The ideal is to perform entrainment, achieve concealed fusion with an in-circuit response, and you've got a very high chance of abolishing that VT with ablation on a site that performs in that way. Perhaps second best or close to first best would be termination with non-global capture. So when you go to entrain it, it terminates without you actually capturing a QRS on that beat. Or a site where catheter pressure terminates the VT just as soon as you touch it. That's another great place to burn. Becoming a little bit less specific, but it would be a site with a presystolic potential during VT. As you know, that site might be part of the circuit just before the exit and a great target, but it could also be a channel potential that's unrelated to the VT. And then slightly less specific again would be an isolated diastolic potential during VT. And of course, you can see quite a few of these spread throughout the myocardial scar. Very quickly, just again for review, because I know you guys have talked about it earlier today, entrainment mapping, let me just see if I can get this to animate, is when you pre-excite the ventricular tachycardia. And if you find a site that's in the circuit, especially in a protected isthmus in the circuit, you'll achieve this phenomenon where your stim to electrogram equals your stim to QRS equals your electrogram to QRS, and the post-pacing interval will match the VT cycle length. And as you move through the scar, you'll see varying responses. So right at the exit site, the electrogram to QRS is going to be very short because, of course, you're right at the exit, as would your stim to electrogram and the stim to QRS, and your QRS morphology changes little. And as you move back, both of those move back from the QRS onset farther and farther. But any of those would be a good site to ablate. And if you are in a channel somewhere deep in the scar that's unrelated to the VT, of course, pacing from there might have a longer delay to exit the scar, and that might not match the electrogram to QRS interval. And just one final example. Here's an entrainment from just proximal to an exit site with a short stim to QRS that's still longer. There's concealed fusion. And here's the return electrogram, and that equals 1 tachycardia cycle length. And of course, this is a great site to step on the pedal. But really, the large majority of VTs are not mappable. And that's either because they're not an inducible VT, they're not sustained enough to map, or far more commonly, they're not tolerated and the blood pressure plummets as soon as the patient goes into VT. So as I said earlier, the two key things are where's the scar and how's the VT getting out of it? And inside that scar, where are the highest value targets? So let's talk a little bit about mapping the substrate and about interpreting the ECG. First, let's talk about interpreting the ECG. It is something that I bet everybody in the room is quite expert at. Here's a patient who had an anterior apical infarct, and they had a VT that was exiting out here somewhere. So this is the VT, and when we pace from this site, we get a near match. It's not perfect, maybe the exit, but that was the best that we could find. So maybe that VT is exiting a little bit epicardial to that site. So of course, our ablation strategy here would be to try to ablate everything that we can see in this area that might be a culprit. But pace mapping is imperfect. So again, here's our VT circuit. It's going around and around through the scar, and this is the protected channel, and here's the exit site. Pace mapping is an imperfect science. If we pace from right at the exit, we should get a great QRS match to the VT. But this might not be a very vulnerable site to ablate. The tissue might be thicker there, and again, it might the actual exit from a protected isthmus might be intramyocardial or epicardial. So that might not be the vulnerable part that we can try to target. As we move farther back, we get more delay. And if we're just proximal to the exit, we'll still have a QRS match. So this is sort of my favorite target during substrate mapping and substrate ablation, is to find something that's a short delay with a QRS match to the VT. We don't always get it. But don't forget that you can also be at a great site. So back here, this is part of this same VT circuit. But if we pace from here, the shortest distance to the exit might actually be out this way. And so you get a QRS that doesn't match. You still get a latency, a delay from stimulus to QRS. But even though it doesn't look like the VT, it still would ablate this VT. So again, this is in some way pace mapping has failed us, but we did see the sign of latency, and that might be a good site to ablate. But you can't use that every time either, because let's say we're up here in the scar. Sure, we get latency, and in this case, we also get a perfect match if this is the shortest route to the exit from the scar. But ablating here doesn't do anything for the patient. So some match between sensitivity and specificity needs to be made, some compromise. So how do we pace map quickly? Well, like I said, it needs a quick interpretation of the ECG, and I'm sure most of the audience is pretty experienced with that. So we'll move through this very quickly, and it requires a good understanding of the ECG and the vectors and their relationship to anatomy. So once again, physiology meets anatomy. We need to understand how the heart's oriented in the chest to generate the QRS. The precordial leads are helpful for determining apex to base, and the limb leads also help with localizing VT. So I like to keep it fairly simple. Think about three major axes: left versus right, high versus low, and apical versus basal. Lead one is great for left versus right, of course. High versus low is your inferior leads and the axis of the VT. And for apex to base, if you have a right bundle morphology in V1, the VT is coming from either the left ventricle or the septum. And if it's left bundle morphology, it's septal or RV. The septum, as I just mentioned, can generate a QRS that's either right bundle or left bundle. If there's positive concordance across the precordium, it's basal. If it's negative, it's apal, and where it transitions in between those two correlates approximately with the distance between apex and base. To show a few quick examples, here we're pacing at the basal anterior LV septum, and we get a straight inferior axis and positive concordance, just as you would predict. And now you move a bit more apical, and you can see we move the transition zone a bit more apical here. Go leftward instead, and you get positive concordance again, but now a more rightward axis and more negative in lead one. As you move left, the axis moves right. And as you go on the apical anterior wall, now you get negative concordance, negative in lead one, and negative in two, but positive in three because you're moving more leftward. And so this follows a predictable pattern which we can exploit to help us localize VT and figure out which margin of the scar is the most likely to be the culprit for any given VT. So as I mentioned, the QRS tells us the action of the functioning myocardium, but all the action is in the scar, which is our arrhythmia substrate. And I like to think of our targets within the scar along this continuum, along a spectrum from being very specific, so activation and entrainment mapping, where you're targeting specifically the VT that is likely to be the culprit for this particular VT, to moving to a larger substrate-based ablation. And now we're starting to target VTs that we have maybe not induced or cannot map. And so we look for the low voltage signal in the scar to define the scar. And then inside the scar, we might look for particular targets. So people have talked about techniques such as dechanneling. I'll show you briefly ripple mapping, deep potentials. People have talked about core isolation, where you try to ablate on the margins and leave what used to be late potentials in the middle of the scar, now isolated, similar to the way you would do a pulmonary vein isolation. And we'll talk about latency. And so here's a picture from ripple mapping. I'll show you another in a few moments. And the Bordeaux group has coined the term LAVA, or late abnormal ventricular activation, that is looking for the abnormal signals inside the scar. So not just low amplitude, but also abnormal signal characteristics, and targeting those specifically with ablation. And then at the sort of most aggressive end of the spectrum, where you're being very sensitive, trying to ablate everything that could possibly have anything to do with VT. Some have advocated for just burning everything that's got a low bipolar signal amplitude. And we don't really know where on this spectrum we should be targeting our efforts. Probably somewhere, towards the right, towards being more aggressive. So let's explore an infarct. One of my favorite things to look for is latency. That is a site where you pace inside the scar with your mapping catheter and see that there is delay more than 40 milliseconds before the onset of a QRS. And that correlates with, that suggests that you're pacing some channel. It doesn't prove that it's part of the VT as I showed you earlier in that graphic, but it is more likely than a site that doesn't capture with latency to be part of the circuit. So I've labeled most of these as either physiologic or anatomic. So this is a physiologic thing inside the scar you might observe. And so latency is the other name for it. We pace from inside the scar, get latency before there's a QRS. And so we know that we're on a channel and that might be a target for ablation. I'm not a big fan of turning up the bottom end of your signal amplitude on your color scale on an electroanatomic map, because lots of important channels have very small signals. So setting that at 0.5 or 0.25, you can still miss lots of very small but important isthmuses. So I usually leave my lower color border very low. And this is a paper from 20 years ago that showed that. And I labeled this slide "cool stuff that you see," because if you do pace around in the scar, you will see really interesting things. And that's mostly what we're going to talk about the next few slides. So here, if you pace faster, you might actually have block. If you find a site with latency and you pace, and then you pace at a different rate, you might find that you block exiting out one way and now are exiting out another way, and see that now you're matching a VT that you've seen or that you've previously produced, or a clinical VT. If you turn down the output, you might capture a multi-component signal differently, capture a different component of it and exit out a different way, and now see that, oh, we didn't have delay at high output pacing, but when we turn it down, now we're capturing a little channel that does exit with delay. So here's an example of lava potentials, just late fragmented potentials that you see in the scar. If you mess around with the color scale of your bipolar signal amplitude, you might be able to identify all or part of a circuit. Again, this is a physiologic maneuver. Rod Tung and his group have coined the term ILAM, that is mapping, performing an isochronal map, not of the activation time, but of latest activation, the latest component of a signal, trying to identify these very late activated components. And where you see a lot of slowing might indicate a line of block and help you identify a good ablation target. Decremental evoked potentials, that term, or deep, that term's been coined by Nantha Kumar in Toronto, based on their long history of intraoperative and catheter-based VT mapping. And again, I put this in along my physiologic phenomena that are observed in VT. Decremental evoked potentials refer to the effect that program stimulation has on signals that you see inside the scar. So if you find an interesting fragmented potential in the scar, and then you pace the ventricle with program stimulation, you might see decrement into the scar, just as you do in the AV node in a supraventricular tachycardia. And that too is a sign of the physiologic behavior of a channel that might mediate VT. And so they did some really nice, elegant recordings that have demonstrated this. Ripple mapping is just another way to image channels in the scar, but I really like it because it's clever. I can't say that we use it routinely. When we convert a map into a bipolar map, we're really reducing all of those signals, each signal to a single value, and portraying it on a color scale. Ripple mapping tries not to ignore the temporal data, and so this is available within the Biosense system. They convert the signal into one of these bars that are showing up as these white bars on the surface of the ventricle, and that's the signal amplitude over time. So you can image the amplitude of signals moving into scar, and it's kind of a nice way to image channels inside the scar and then specifically target them. So this is both a physiologic and an anatomic measure. Moving just to anatomy, again, the Bordeaux group has come up with a music software, and they create, really, they're just analyzing imaging, either MRI or CT, with an expert technician who's then able to graph thickness and image scars through the myocardium. And if anyone who attended the VT symposium this year in New York would have seen that their live case was using purely an anatomic-based approach to ablate VT. Now kind of bridging both the anatomic, the physiologic, and now maybe the mathematical, Natalia Trajanova and her group at Hopkins have modeled VT. So they take a high definition image of myocardial scar and then calculate where they think VT ought to be. They actually create a myocardial model from that individual patient and then subject it to programmed stimulation, making certain assumptions about conduction velocity through the scar, and image where they think VT circuits would be. And I'm not sure this is in clinical use, but it's certainly an interesting way to kind of think about how we might image VT maybe for the future. Speaking of imaging VT, ECG imaging is a method for taking the body surface ECG and converting it into a map of ventricular activation, pioneered by Yoram Rudy and his group in the States, and then eventually bought by Medtronic. We didn't have that, so we kind of had our own, and this is one of our patients. We take the CT scan and 120 body surface potential leads, and then use the recordings from the body surface to calculate what must have been happening on the epicardial surface, and then to try to use that to localize where VT was coming from. And when so this technique, especially by Rudy, has been subjected to quite a lot of validation, both in simulations, then torso tank models, then in vivo animal studies, and finally human validation. There's a nice review that we did in 2018. So we tried to validate this with epicardial mapping during and body surface potential mapping during VT ablation. And we showed that the accuracy in localizing VT was somewhere on the order of 13 millimeters in the best case scenario. And that's not a far match from what the London group of Pierre Lambiase achieved using the Cardio Insight system. So this has maybe a little bit less utility for actually mapping scar during sinus rhythm. But I would say that this is a technology in evolution. I'm hoping that we will eventually be able to non-invasively map scar physiologically, not just with imaging. But like I say, I think this is a technology in evolution. So we have tried to do this. It's pretty difficult to validate it against a gold standard. But we are able to, in some way, image myocardial substrate. I'm not sure it's ready for prime time yet. And then as we sort of come into the home stretch here, that ECG imaging is technically challenging and complex. And so we've tried to dumb it down. And you'll see Dr. El-Damaty was part of this work in which we took not only body surface potential maps, but 12 lead ECGs and tried to use that to localize VT. And it's really using the ideas I talked about earlier, turning the QRS into an integral, so simplifying the electrocardiogram, using the axis and the transition to try to localize VT. And if you divide the ventricle into a polar map, just like the echocardiographers do, and into segments, then each segment has a characteristic map for VT that's arising from there. And it turns out you can use that to localize VT. And so we've worked on this for quite a few years. And the accuracy, especially if you incorporate some pace mapping into it, is actually very good, with an accuracy that is less than 10 millimeters, which sort of I think is where you'd want to be for catheter ablation. And in fact, sometimes it's quite a bit better, more on the order of 5 millimeter accuracy. And we've been able to validate this in vivo in humans and work on turning it into something that can be used in real time. Okay, so to finish up, when we're mapping VT and mapping VT substrate, what we really have to do as a key success determinant is integrate our knowledge of the scar anatomy with scar physiology to identify targets for ablation. And I've outlined to you about 12 different methods for doing that. We actually don't know which of those is the best. In our lab, we combine the voltage map with latency mapping, VT localization, and frankly, any of the above that we notice either on purpose or by accident during mapping, and try to concentrate our ablation efforts on the highest value targets. We will perform ablation of substrate that may not be associated with a VT that we've induced or seen clinically, but we tend not to blanket the entire scar with ablation. We're really trying to balance patient safety. I think by focusing on the highest value targets, we can be more successful with those targets and not spend extra time on targets that may be of lesser value. But I don't really know that. There's no really good science on exactly which targets ought to be ablated during VT ablation. So I'll stop there. Hopefully it hasn't been too long a session, and I think there's an opportunity for discussion and questions at the end. Thank you so much for your attention.
Thank you, Dr. Sapp, for this very in-depth lecture. I'm Dr. Mervat El-Damaty. We met many years ago.
Yes, Dr. Mervat, nice to hear your voice.
We have many electrophysiologists, young generations, and senior electrophysiologists here. But I will ask you a question about the future. We haven't seen it yet, but some cases in Germany, one of my fellows sent it to me, which is the radiotherapy isotopic treatment of incessant VT in very high risk patient using the MRI guided approach. I want to ask you, is this the future for VT ablation?
Yeah, radiotherapy?
Yes.
Yeah.
Direct cardiac MRI.
Yes, so a purely anatomically directed radiotherapy. That's a great question, and I can't see the future. We are fairly early in our experience with radiation for VT. We are using a combination of imaging and EP study and ECG localization. And it's a struggle. I am not certain of the effectiveness now. There is a randomized trial that will be starting soon, comparing radiotherapy to catheter ablation for VT. And I think that will be very useful. There's a lot of research right now on the optimal way to target VT for radiotherapy. So as you know, the original series used CardioInsight. That's expensive, and it means that you're only targeting inducible VTs. One of my colleagues who used more of a pure anatomic approach, where they were using 3D imaging of the scar, they noted a fairly high adverse outcome rate. But again, those are very sick patients, and there's not a control group, so it's hard to know exactly whether that is the best possible outcome or whether it was not targeted enough. So I think I wish I could see the future on this one, but it is definitely an evolution. And I think the efforts of many centers around the world are now focusing on this.
Okay, thank you for this future answer. We'll wait for this in the near future. Another question, you were in the group trying the needle, the ablation needle of Dr. Stevenson. He presented in London VT about the success. As you, I think you tried some, you tried some of needle ablation, RF needle ablation.
Yes.
Okay,
Yes.
we need to hear from you your current experience. This is off label, not FDA approved yet. Well,
Right. The needle catheter works. So we actually developed it. Dr. Stevens and I developed it when I was a fellow 20 years ago or more. And we took it through animal studies, and first in human was actually here in Halifax. And then we did a multi-center experience, and it does work. It makes larger, deeper lesions and is effective in patients who have failed multiple other therapeutic attempts. It is no longer available in the Biosense needle. Biosense elected to stop manufacturing it. There is another needle catheter that's in trials that has been reported now at, I forget where it was reported, but the papers are out as of 2022. There's a Canadian journal paper by Atul Verma and an American paper by Doug Packer of the thermedical needle. So that's a larger needle with multiple side holes. And again, there are risks to being more aggressive with the needle, but it does seem to be effective in making myocardial lesions and treating VT.
okay, thank you very much. And we'll ask the floor to give you hard questions from young people.
Professor Saab, we have here a couple of questions. I'm Ahmed. I will start with a quick one. We were talking earlier about the lack of a standardized protocol for substrate mapping and ablation, and the fact that several centers are doing their own approach. Do you think that we might be able to get a standardized approach in the future, or is it the nature of the substrate and the type of patient that we are dealing with is the limitation, and that's what dictates the fact that we have several approaches?
Oh, I think it's less intelligent than that, Ahmed. I think the reason that there's no standardized approach is because electrophysiologists are cats, and you cannot herd cats. So everybody has their own approach. And in fairness, we're all looking at the same thing. We're all looking for that cool stuff inside the scar, the abnormal physiology inside the scar. And you can identify it in lots of different ways. There's no really great science comparing one to another. So as I said, I showed you a whole raft of different potential targets in the scar, but we don't know which is the best one to target. Maybe all of them, and finding just the right balance. The only trial, as you probably know, was the VISTA trial, but they really compared ablating everything with a voltage below 1.5 to just ablating the clinically seen VT and ignoring other VTs. So no surprise that doing more leads to less VT later on, but it doesn't really test, do you have to ablate every single thing with a low voltage versus being more targeted with and being more specific for substrate within the scar.
Yes, Professor John, thank you for the magnificent lecture. I was wondering, in your experience, when do you refer patients for example, cardiac sympathectomy? And what are the tools that you use? Is it a limited thoracotomy, thoracoscopy? There is this ultrasound guided block with just local anesthesia and alcohol injection. Where do you find this fitting in your patient care?
That's a great question. And the answer is we haven't. You really need the people who can do that. And that person's not me. So, I really like that body of work that's examining sympathectomy. Is it better than nadolol or propranolol? Maybe. But I also like the idea of the targeted ultrasound anesthetist block rather than going directly to surgery. The UCLA group has some dedicated surgeons who have become quite skilled at doing it with a low incidence of Horner syndrome and relatively high success rate. We don't have that, so we have not been using it.
Thank you, Dr. Saab. Just for more information about mappable, unmappable VT, we were talking the last VT summit about alcohol ablation through the venous system of the heart. Like, for example, in a scar area that I can't, for example, ablate and get much response during ablation. They do like small venous alcohol ablation to these scar areas, just getting the benefits of that. What do you think so?
Yeah, the work by El-Damaty has been really very interesting. As you probably know, some of the early work was transarterial ethanol, and the very early series had a fairly high complication rate, and so it was sort of set aside for a few years. And then, as mapping got better, it got reapproached, and it is an effective way to create a lesion through the venous system. Might be safer, and like I said, the Texas group has really done a great job elucidating this. We have not pursued it locally. We sort of, you kind of have to have one thing that you're going to do when your catheter ablation is unsuccessful, and our stepwise approach used to be the needle. Now it's either epicardial or radiation is what we've been trying.
Okay, just another question about during the VT that, for example, unmappable due to hemodynamic instability. I was thinking about, for example, when you are measuring the inter-QRS complex duration and they try to correlate it with the deep technique, so you can identify which, like for example, isthmus according to the duration and the velocity of the signals that are moving during that, and you can correlate which is the, for example, which is the, we can say that isthmus dependent VT of this area or undependent, for example, different isthmus according to the deep technique stimulation. Like, for example, if you are measuring the velocity of the signal starting from one point to the end point, this is the isthmus, for example, and you are trying to correlate it with the inter-QRS complex during the tachycardia itself. Is it possible or not?
Our audio is unfortunately breaking up a little bit. I'm not sure I fully understood the question. Using the deep technique, you can identify channels that have abnormal physiology within the scar that are more likely to be related to a VT. I'm sorry, I wasn't catching what you were saying about the QRS duration.
I'm talking about if you are measuring the inter-QRS complex duration during the VT itself, and you try. Okay.
Intra-QRS duration.
During the tachycardia, during the VT itself, when you are measuring between the QRS complex and the QRS complex, there is during the cycle length itself. Okay, this is the isthmus correlated with the deep.
Yeah, maybe we should discuss offline. I'm not exactly sure I'm following you.
Professor Saab, I think the question here is there a correlation between the tachycardia cycle length and the deep signals that you find with deep mapping? As far as I can know.
Okay, yeah, actually, I'm not sure. I'm not sure of that. There likely is. Yeah, you'd expect there to be. We have not really systematically assessed deep mapping. Partly, you can only do so many things when you're in the heart, and we tend to spend a bit more time pacing from the mapping catheter than doing program stim from outside. So I have not explored that in detail. It's very likely that there is a correlation between the degree of decrement. I mean, just really analogous to what you would see in SVT. It's very likely that that's the case. Yes.
I guess one last question.
Yeah, I'll try to make it quick. Thanks you very much, Professor Saab, for the excellent talk. Being interested in deep lesions and develop the needle catheter, what's your point on bipolar ablation in the armamentarium of trying to achieve deep lesion, whether by endoepicardial ablation, needle, alcohol ablation, and recently the bipolar? Do you think it will be the answer to deep lesions?
Yeah, I do. I think it's going to be, I don't know which technology is going to be the one that gains widespread traction, but certainly a better bipolar method would be great. Most of the attempts at bipolar ablation have been not only off-label, but, people taking electrical wiring and kind of splicing it together and putting some black tape on it and hoping for the best. But there are some systems that have become available, I believe, I think in Europe, that allow you to actually, plug and play to do bipolar ablation. That is one way. It does work. It does create deeper lesions than sequential unipolar on either side of the tissue. And it's deeper even than using two RF generators at two sites across if you actually deliver ablative energy between two catheters. And it might be a bit more precise as well, but it's technically quite challenging, to find a spot where you can get two catheters on either side. But I really don't know which of these technologies is going to sort itself out as being the go-to, easiest, most approachable one. I'm pretty optimistic about radiotherapy, but again, it's just going to have to prove itself, under hard scrutiny.
Okay, thank you very much, Dr. John Sapp. And one last comment, you look younger than we saw you in Egypt. You play sports and you eat healthy. And I hope all cardiologists and electrophysiologists will follow you as a good example. Thank you very much. Wish you continue with us later in February, as Ahmed is going to make many arrhythmia camps. This is the first episode 1, and then we'll wait for you in the next and third episode. Thank you very much.
Thank you, Dr.
So, thank you very much for freeing up the time to be here, sharing with us your very valuable experience. And we were looking forward to future collaboration, perhaps physically in Egypt. Thank you.
Thank you very much.
Okay. Hello, Dr. Rania Samir. I have the pleasure to present our dear colleague and friend, Dr. Amir Abdul Wahab, our ambassador back in Canada. He's now in Canada, I think. Yes, he's the professor of cardiology at Cairo University and associate professor of medicine, Heart Rhythm Service Division of Cardiology in Dalhousie University, Halifax, Canada. We have the pleasure to welcome you here with us today, Dr. Amir. It's been a long time since we've last seen you, and we hope to see you next time physically here in Egypt. Now he will present to us the lecture with the title of Sudden Cardiac Death, Current Status and Novel Method of Risk Stratification.
Thank you so much for the introduction, Dr. Rania. I hope that you can hear me well. And you can see my slide?
Yes, we can hear you well, and we can see your slides.
Okay, perfect, excellent. Thank you for giving me the opportunity to participate in this great symposium. I enjoyed listening to some of the talks from yesterday and from this morning. Really very well done. The topic that I'm going to be speaking about is the topic of sudden cardiac death. I'm going to try to focus on new knowledge that we have in the field. So let's start by the basic definition. So the definition of sudden cardiac death that has been incorporated by several societies is the sudden natural death that is presumed to be cardiac cause that occurs within 1 hour of onset of symptoms, if these symptoms are witnessed by someone, or within 24 hours of last being seen alive when it's unwitnessed. And just based on that definition alone, you can see that the difficulty really in identifying patients who truly have sudden cardiac death. It is thought that about 50% of all cardiovascular deaths are sudden, and about half of these could be the first manifestation of a cardiac disease. Sudden cardiac death is becoming a global problem. It's estimated that between 2 to 7 million victims die every year because of this. And when it happens, it's very bad in terms of the prognosis. 90% of patients die, and even those who can be resuscitated, they may live with significant functional and cognitive disabilities. So it's a major problem. And given the loose definition, I like this paper which examined patients in San Francisco who had autopsy following a presumed sudden cardiac death. And you can see on this graph that the actual cardiac death in these patients is a little bit about 50%. This is represented by the shades of the red color. And if we look here, about 56% of those patients had actually an arrhythmia-related sudden death. So that gives us an insight that sudden cardiac death is mostly arrhythmic in nature. Some of it could be related to acute coronary artery disease or chronic coronary artery disease, but still ischemic heart disease represents about 1/3 at least of those cases. So sudden arrhythmic death is what we're going to be talking about today, because we are electrophysiologists. And it's mostly related to ventricular arrhythmias, whether VT or VF. VF is the usual presentation with acute events like acute MI or any acute cardiac events, and VT tends to be related more to re-entry, related to myocardial scar. We've seen the great talks this morning about the mechanism of scar through the surviving channels, mechanism of VT, through the surviving channels in the scar. There is another category of arrhythmic death in the form of pulses, electrical activity, and asystole that we really don't know much about, but there is a trend that this may be increasingly identified in patients who have sudden cardiac death. In terms of what we can do about prevention, probably preventing acute events relies mostly on guideline-directed medical therapies and management of risk factors, but preventing sudden death related to VT and to lesser extent VF can be achieved with implantable cardioverter defibrillators. We still know little about what to do about PEA-related sudden arrhythmic death. So my focus will be mostly related to ICD utilization in terms of preventing sudden cardiac death and how we can get the most benefit out of this available technology. As you're all aware, ICDs are effective in preventing sudden cardiac death. They can provide reliable defibrillation and allow also for bradycardia pacing. We know that based on many years of clinical studies, the three main studies for secondary prevention for patients who have previously sustained ventricular arrhythmias, AVID, SIDS, and CASH, show clearly that there is a mortality benefit, total mortality and arrhythmic mortality benefit from ICD implantation. And also in the primary prevention population, patients who had who has not experienced a sudden cardiac death or a ventricular arrhythmia event in the past, we know from the MADIT-2 study and the SCUD-HEFT studies that ICD can save lives. ICD can reduce the total mortality and risk of arrhythmic death in patients with ischemic cardiomyopathy. And this was the basis for which the guidelines now incorporate ICD implantation for primary prevention. The inclusion criteria in this study were patients with reduced ejection fraction below 30 to 35%. The story is not very clear in patients with non-ischemic cardiomyopathy. These are data from the DEFINITE study and non-ischemic cardiomyopathy population in the SCUD-HEFT study. In those two studies, there was a trend towards a survival benefit for ICDs, but in both studies that did not reach statistical significance. And you're all aware of the more recent Danish study for patients with non-ischemic cardiomyopathy, which was negative in terms of overall survival. However, on analysis, the post-hoc analysis, there was a trend towards a survival benefit in younger patients who within the age group that is less than 59 years. So based on these studies, ICD is now recommended for patients who have ischemic or non-ischemic cardiomyopathy with a reduced ejection fraction. But if we look into the spectrum of sudden cardiac death in the whole population, the story may be a little bit different. So this is the Meyerberg curve that was described many years ago in the 1992. And that shows the incidence of sudden cardiac death in relation to the substrate that we have. So people who experience a VT, VF, or as a cardiac arrest event have a very high incidence of sudden death. And people with a reduced ejection fraction below 30% have still a high incidence of sudden death. But patients who had prior MI with preserved ejection fraction, or even patients who did not have an MI but were known to have coronary artery disease or coronary artery disease risk factor, they have a lower incidence of sudden cardiac death. But the problem is that those patients represent a bigger cohort of people. And so the actual number of people at risk for sudden death is probably bigger. So if we apply the guideline criteria that we have based only on the ejection fraction, we are only able to capture this group of possible sudden cardiac death victims. But the majority of people at risk of sudden cardiac death, probably we don't pick them up with the current criteria for implanting defibrillators. There's also some challenges that we face when we are talking about sudden cardiac death risk stratification. So the first problem is that the risk is actually continuous. It's not dichotomous. It may not be accurate to pick a certain number of ejection fraction and base our clinical decision on it. This work shows that the risk of the hashed line here, that is the risk of sudden death actually increases as the ejection fraction increases. So even in this category of patients who have a moderately reduced ejection fraction, there is still a residual risk of sudden death. And the other important thing as well is that it's not just the sudden death risk increases with reduction of the ejection fraction, but also the risk of non-cardiovascular death, labeled here in black, and the risk of heart failure death also increases with the reduction of the ejection fraction. ICDs do not do anything for non-cardiovascular deaths or heart failure deaths, and that's also important to keep in mind when we're interpreting the effects of ICDs in terms of preventing sudden death in general. The other problem with sudden cardiac death risk stratification is that the actual risk is dynamic. The risk changes per patient, it changes also per population, and it also changes over time. Let's speak about that a little bit. So this work was really interesting because if you take patients who have a relatively preserved ejection fraction around 40% initially, immediately post-MI, most of those patients with medical therapy will have an improvement in their ejection fraction over time. However, there is a decline in the ejection fraction in about 26% of patients, and that decline can be to the extent of about 9% reduction in the ejection fraction. So if you do only one assessment of the ejection fraction 40 days after MI, which is what the guidelines recommend at this point in time, and base your decision on that, you are probably missing 26% of patients who have further decline in ejection fraction. Not only that, their data also shows that people who have an improvement of their ejection fraction over time actually have better chances of survival. So if you have a 10 degrees improvement in the ejection fraction, then your risk of fatal or non-fatal cardiac arrest is low. But if there's no change in the ejection fraction compared to baseline, then the risk increases. So the concept of changing risk based on changing ejection fraction over time is important because this will affect the long-term risk of having sudden cardiac events. The other issue is the risk is different between populations. I want to show you an example for that. So these data suggest that the mean life expectancy varies according to different populations. So this data from 2020, the mean life expectancy in Egypt is about 71 years. In countries like Canada, it's about 82 years. So if we're making a discussion about somebody at the age of 70 for whether a primary prevention ICD would be a reasonable thing or not, we have to keep in mind that how much life expectancy that we are talking about in this specific population. Also, different countries have different risk of cardiovascular mortality and consequently risk of sudden cardiac death. This data suggests that probably if we count all the deaths that are reported due to cardiovascular disease, there is about 3 to 4-fold increased risk of cardiovascular mortality for someone who's living in Egypt compared to someone who's living in Canada, for example. Part of this data could be related, like part of this may not be very accurate because it may be related to the way deaths have been reported in Egypt, but at least it's a trend. So the data suggests that people may die younger because of a cardiovascular disease in countries like Egypt, and we have to be more aggressive in terms of identifying those and trying to mitigate that risk. The other concept of dynamic risk is the changing risk over time. So if you look on the left here, this graph shows the mortality risk for different sudden cardiac death trial. So in the initial trials in the 90s, the risk was generally higher. If we compare that to the more recent studies like the MEDI2 and the SCUD-HEFT and even the Danish study, you see there is a trend towards a lower mortality risk over in these trials. And this is probably reflective of the better ways of managing cardiovascular diseases in terms of pharmacological therapies or primary PCI, for example. Definitely those things are resulting into a better impact in terms of the total cardiovascular mortality. But this also represents a challenge to us when we're talking about ICD efficacy. So the number needed to treat in the earlier studies to prevent sudden death with ICDs was much lower compared to the number needed to treat with the modern studies. with the establishment of the good medical therapy that we have currently. So applying the results of studies that have been done more than 2 decades ago at the current time is probably not very accurate. So we have to keep all those things in mind when we're talking about the risk of sudden cardiac death. And the last thing that is really important is, and becoming more like recognized recently, is the competing non-arrhythmic risks. So patients with who had a reduced ejection fraction or an ischemic cardiomyopathy, for example, they have a risk of sudden cardiac death, but probably they have even a higher risk of competing risks that can cause death. We're talking about heart failure deaths or non-cardiovascular deaths in that situation. So we have to be conscious of that. So the ICD may reduce the risk of sudden arrhythmic death, but it will do nothing for those competing risks. Let's take a clinical case just to show that concept. This is a patient that is not uncommonly seen in the clinic for assessment regarding a primary prevention ICD. A 70-year-old gentleman who had a remote anterior MI, NYHA function class 3 with an ejection fraction of 10%. These are his medications, reasonably good heart failure medications, and blood work showing some anemia and renal impairment with the creatinine of 200 millimoles. That translates to about 2.4 milligram per deciliter. He doesn't have an indication for cardiac resynchronization therapy. So this is an example. If you apply the guidelines blindly on somebody who's like that, then you would say that this patient probably qualifies for a primary prevention ICD. He has a reduced ejection fraction and ischemic cardiomyopathy. But if you look deeply into those details, using things like the Seattle heart failure model to try to assess what is the annual mortality of this patient with these conditions, it's actually 24% annual mortality, just based on the factors highlighted in red here, which are incorporated into the Seattle heart failure model. And if you look further, the Seattle heart failure model can provide you with an survival curve for that patient and you can test what would be the shape of that curve with every intervention that you do. So based on that calculator, the black line represents the expected survival for this patient without an ICD. The red line represents what the ICD would offer in terms of improving the life expectancy. As you can see here, the life expectancy 3 years based on these parameters, and that can be increased to 3.2 years. So very minimal effect of implanting the ICD. That speaks probably that this patient is probably at a much higher risk of non-arrhythmic death compared to arrhythmic death given his circumstances. So we have to be conscious of that concept as well, the comorbidities and their competing risks. So the second part of my talk will be related to how can we improve our risk stratification for sudden cardiac death. There are 4 main domains that we can look into when we are trying to find predictors for sudden cardiac death. The first thing is the anatomic substrate. I think Dr. Sapp explained clearly how important it is to know the anatomy for VT ablation, but also important to know it for predicting ventricular arrhythmias. The second domain is related to autonomic measures. So why does the arrhythmic event happens in this particular day at this particular time? We still don't know why, but it's probably related to some changes in the autonomic tone to the heart at this particular moment that initiates the ventricular tachycardia or the ventricular fibrillation. Repolarization measures are also important for things like, especially for things like ventricular fibrillation, because these could be the triggers starting that triggered activity related to the ventricular tachycardia or ventricular fibrillation, as well as phase 3 re-entry involved with ventricular fibrillation. And there's also some provocative tests or ECG monitoring that we can use. So let's go over these things. We'll try to pick the more pertinent measures within those categories. So in terms of the anatomic substrate, ejection fraction has been used, as we discussed in many studies, as a marker for the presence of myocardial scarring. But there are tools that allow for direct assessment of the scar itself. These could be direct imaging, like MRI, SPECT, or PET, or they could be indirect and based on the ECG that we can see in terms of the QRS duration or the QRS fractionation, or even the signal average ECG to look for late potentials. What about the ejection fraction? So it's a crude marker of scar burden. It's easy to measure. It can be measured by different modalities, echo, MRI, like nuclear testing. All those things can assess the ejection fraction, so it's easy to measure. And it was the inclusion criterion for all the primary prevention studies. So we have a very good evidence that it works. It can identify some patients who are at risk of sudden death. But there are problems with the ejection fraction. So this work is that was the work of Sharif Osama. I'm not sure if he's in the audience or not, but actually, if you have patients with ischemic cardiomyopathy and you measure the ejection fraction with an echo compared to the gold standard, which is MRI, you get on the average about 7.5 points higher on the echocardiogram assessment. So if you get an ejection fraction of 40% on echo, that probably may mean that if you do an MRI for this patient and check the ejection fraction, it's probably lower than this number. So there's a great variation between the measurement of the ejection fraction based on the modality that you choose to use. Ejection fraction is a very poor test in terms of its sensitivity and specificity for identifying sudden cardiac death. On the left here, there are several series of patients who had with ischemic cardiomyopathy. The sensitivity of ejection fraction in terms of detecting the risk of sudden cardiac death is very low. It's about 25 to 30%. And in those who receive ICD based on that, only 20% of those patients, or even less, may experience appropriate therapies. So it has a specificity that is less than 20%. If I tell you that there is a test that has a sensitivity of 30% and the specificity of 20%, probably will laugh at me like, what kind of test is this? But unfortunately, this is the only test that we have now in order to identify patients at risk of sudden death based on the guidelines. I'm talking about in clinical practice. What about directly assessing the myocardial substrate, the myocardial scar, sorry? It is superior. Studies have shown that it's superior to ejection fraction in predicting the ventricular tachycardia or ventricular fibrillation or appropriate ICD therapies. And it also can identify the type of the scar. So we know that heterogeneous scar is the scar with surviving myocytes in the middle of that scar. Those surviving myocytes can represent the channels needed for re-entry for VT. The problems with the scar identification is that it has limited availability because this requires usually an MRI or a PET scanning. And also we don't have prospective studies based on, that assess the efficacy of ICD therapy based on scar imaging. This was from the work that Sharif has done. We had assessed the scar burden based on MRI imaging, and the only independent predictor for spontaneous VT was the total scar burden. Ejection fraction was not predictive in our series, and the same for inducible VT at the EP lab as well. So the only predictor was the total scar burden. And this work has been shown with other groups as well. Like this study involved in cardiac MRI for patients who had ischemic events, and you can see that patients who have less delayed enhancement on their MRI images did better than those who had higher burden of scar based on the delay enhancement images. And based on that, they tried to do a study that's called Determine that wanted to use the MRI as a risk stratifier. So patients who have a positive MRI would go for an ICD. Patients who have a negative, would be randomized to either receiving ICD or not. But the problem with that study is that the enrollment has been very slow, and the funding was withdrawn in the middle of that study. And that's a challenge with all the studies that try to use novel risk stratifier markers for assessing the benefit of ICD therapy in those populations. The second domain is the autonomic measures, things that assess the sympathetic and vagal innervation of the heart, like heart rate variability, heart rate turbulence, baroreceptor sensitivity, or direct imaging of the autonomic innervation of the heart by SPECT or PET, have all shown a benefit in terms of some benefit in terms of predicting sudden death. I'm going to speak here briefly about the heart rate turbulence because it's easy to obtain. It requires a Holter monitor, and the algorithm that is used to measure it tries to assess the response after a spontaneous PVC. So you get a short RR interval with a PVC that is followed by a long RR interval for a compensatory pause, and this is followed by early acceleration of the sinus rate and followed by late deceleration. So the late deceleration is what represents the vagal innervation to the heart. This is the norm, and then you overlap this for the number of PVCs that you have during the recordings, hundreds of PVCs, just to get this curve. This is the normal response is to see this early acceleration followed by the late decelerations. Patients who have an abnormal response usually lose the acceleration, the deceleration that happens after the PVCs, and this has been shown to be associated with increased risk of future arrhythmic events. What about repolarization measures? Things like T-wave alternance or QT dispersion variability, QT interval itself, and the duration between the peak and the end of the T-wave. All those things have been reported in retrospective studies to be predictive of arrhythmic events. I'm just going to speak about the T-wave alternance. It's again, it can be easily obtained from a special Holter monitor to look into the T-wave and variation in the T-waves, beat to beat variation in the T-waves. It was shown that patients with positive T-wave alternance results are at a higher risk of arrhythmic events. And the last domain is the provocative testing. And here we're talking about EP studies and ambulatory monitoring for PVCs and non-sustained VTs. Programmed ventricular stimulation was very frequently used in the past. It was a pre-requirement for the MADIT study in the 90s. And in the MUST study, again, which is a study for patients who had ischemic cardiomyopathy and ejection fraction less than 40%, it was part of the assessment of those patients who had a programmed stimulation. But the reason this has not been utilized anymore, because in these studies it showed, although it had a good positive predictive value, non-inducible patients still had a high risk of sudden cardiac death at 2 years, about 12% risk of sudden cardiac death at 2 years. And for that reason, we moved away from doing programmed ventricular stimulation routinely in patients. So our current risk stratification model relies on a single stratifier, which is the ejection fraction, to determine what patients are at a lower risk and at a higher risk. There are potential new models that can help in terms of enhancing the risk. So the idea is either through a parallel risk stratification or a multivariable serial risk stratification. So if we take a risk marker from each of those 4 domains that we spoke about, we can define like a risk score that can allow us to classify patients to high risk, moderate risk, or low risk. This can be done parallel, like for all patients, or alternatively, we can do some initial testing using 1 or 2 of those domains to identify patients at lower risk, and then the remaining patients would be subjective to other kinds of tests to determine their risk, whether it's moderate or a high risk. This was proposed by Mark Dale from British Columbia as a potential way to look into risk stratification in the future. And the only study that is still enrolling is the REFINE ICD study. So this study is based on the fact that if we combine the reduced ejection fraction below 50% together with an abnormal heart rate turbulence and abnormal T-wave alternance, there's actually about 9-fold higher risk of arrhythmic events in these populations. And that was the basis for that study. So this is a study that initiated by Dr. Exner in Calgary, and we are participating in it, that randomizes patients who have post-MI patients who have an ejection fraction between 36 to 50%, and have an abnormal Holter in terms of abnormal heart rate turbulence and T-wave alternance to either usual care or usual care plus ICD. This study has been enrolling since 2011. It's expected that there will be a mean follow-up of 8 years, and it's about at 85% of the target enrollment. So the results of that study will be interesting, because this will be the only randomized study that will tell us whether using those novel markers on top of the ejection fraction would have an impact on the long-term survival of those patients if ICD is used. The data about non-ischemic cardiomyopathy is probably even murkier than the data related to ischemic cardiomyopathy. The problems are non-ischemic cardiomyopathy patients are a heterogeneous group of populations. The risk varies depending on the underlying cause of cardiomyopathy. They have a higher incidence of non-arrhythmic death compared to ischemic patients. And the risk is poorly defined, and say the same applies for the risk markers as well, that the test that we spoke about, the data about utilizing them in non-ischemic cardiomyopathy is weaker. Probably the thing that is striking for patients with non-ischemic cardiomyopathy is the utilization of MRI. In this study that was reported recently, who studied patients with non-ischemic cardiomyopathy, about more than 1,100 patients who were followed for 36 months, they found that the presence of late gadolinium enhancement is probably a better predictor of risk compared to ejection fraction. So if somebody has no LGE on their MRI and their ejection fraction is above 20%, they still have a low risk of events. If patients have an LGE, abnormal LGE, plus a reduced ejection fraction below 35%, this is the highest risk category for sudden cardiac death. And depending on the pattern of distribution of the LGE, patients can be classified into intermediate to low risk or intermediate to high risk. Although this is a retrospective study, they try to assess the sensitivity and specificity for using MRI to further refine the risk. The area under the curve for this algorithm was doing better. It was 82% for that algorithm compared to the cutoff of ejection fraction of 35%, which was only 69%. So there is a potential that MRI can be helpful in this group of patients to better identify risk. Talking about the future, there are major developments going in the field in terms of trying to use the machine learning in order to assist in sudden cardiac death prediction. This novel work from Dr. Trayanova and John Hopkins, using machine learning algorithms applied on the raw images from cardiac MRI, combining also all the covariates, the laboratory, ECG, and clinical variates, and assessing for the sudden cardiac death events in this population. This allows the creation of a probability curve for every patient in terms of survival. I'm just going to show you, these are two examples. This is a victim of sudden cardiac death. And this blue line represents the survival curve that generated by this technique for this patient. You can see here the dotted line is when this patient developed his cardiac event. And this was very closely related to when this line of probability crossed the 50% mark. to compare that, this is another individual who did not have a cardiac arrest event. You can see clearly that the survival probability for this patient did not cross the 50% mark within this period of follow-up. It was like 6.5 years almost. So artificial intelligence and machine learning can probably assist in terms of sudden cardiac death prediction, but still there's a long way to go to see the utility of this in clinical practice. So what about the future? My vision for the future is probably integrating all the markers that we spoke about, including the clinical data, ECG markers, even some serum biomarkers, probably genetics as well, as well as the population-based data in different regions of the world, because this is important. The risk varies depending on where you are living in the world. This may need the utilization of artificial intelligence or machine learning in order to be accurate in terms of risk prediction. And of course, this does not take away the importance of good clinical judgment in order to define every individual patient's risk. So to summarize, I think as you've seen, sudden cardiac death risk stratification currently, based on the clinical practice guidelines that we have, remains to be primitive at most. It hasn't changed at all for the last 25 years. Although there are several novel risk markers that are available that show promising results in terms of predicting events, their clinical utility, their impact on outcomes, and even cost effectiveness, if we're talking about something like MRI, are still lacking. The future will be related to multi-parameter risk assessment that hopefully will allow for better identification of individual risk. But again, this needs to be confirmed in prospective studies. And thank you very much for listening.
Thank you, Dr. Amir, for your elegant talk about sudden cardiac death and its risk stratification. And we're open now for this.
السلام عليكم دكتور أمير، وأنا ميرفت أبو المعاطي. Welcome back to your motherland. We are very proud of you طبعا. أنت سفير مصر في الإكوفيسيولوجي في محافظة كندا. احنا سعداء جدا بهذا اللقاء، وطبعا انت مع الدكتور احمد ضماطي ومعانا في شعبة كهربة القلب ان شاء الله في لقاءات زوم ولايف، وان شاء الله لما تيجي مصر برضو يبقى في حاجة فيس تو فيس كده عشان تفيدنا بعلمك. انا بس هقول حاجة، ان طبعا انت قارنت بين مصر وكندا، فيعني هم ساقعة قوي واحنا دافئة قوي، يعني الدنيا برضو مختلفة يا ابني. لكن طبعا احنا ما عندناش الريساسيتيشن اللي موجود في بلاد بره. يعني مش عايزه اقول لك مره حد جاله كاردياك اريست في مجلس الشعب ما كانش فيه ديفيبريليتور ولا حاجه، وفي واحد مثلا واحد من زمايلنا انقذ طفل ريساسيتيشن في نادي وادي دجله، فما الاسعاف جه ما كانش فيه ديس شوك. فيعني انت بتقارن المانجا بايه؟ يعني بتقارنها بايه؟ ما ينفعش. يعني بصل اخضر مع مانجا لا ما ينفعش. فهي طبعا مقارنات مش في صالحنا. ف يعني احنا عندنا اللاك اوف نوليدج للدكاتره نفسهم. ده حتى ده اللي بيجي له ارست، دكتور تخدير يجي له ارست في اوضه العمليات ويموت. طب حتى يعني ما بيتحطش على فنتليتور حتى ويعدي. كل شويه واحده بنت في النبطشيه وتموت. طب حتى ما فيش اي احساس يعني بالمشكله الجسيمه. دلوقتي المفروض النوادي كلها، قاعات المحاضرات، الفنادق، الشوارع، محطات المترو، محطات القطر، يبقى فيها الاوتوماتيك ديفيبريليتور. ده هم بيشيلوها من عربيه الاسعاف. انا فاكره متذكره جدا اول اوتوماتيك ديفيبريليتور شفته كان في اوضه القسطره في الدمرداش، فبقول لهم جبتوه من عربيه الاسعاف، خلعناه وجبناه لكم. وده كانت اول مره اشوفه فعلا يعني. فمشكله السادن ديث احنا عملنا استادي كده مش عارفين حتى ننشرها، حتى نشرها صعب. في عين شمس كانت حقيقيه فعلا، وجبنا من الفاميليز اللي عيالهم ماتوا او يعني سرفايفد باي سي دي او وات ايفر، ولقينا ان المشكله جسيمه عندنا في مصر. والاهالي هم ما بيجوش الا لما عيل يموت، عيل واثنين وثلاثه طبعا. وطبعا احنا عندنا زواج الاقارب. معانا امنيه في اسوان بمشكله كبيره جدا طبعا في جيفرسون نيلسون سندروم، وبيشوف عيل واثنين واخ وابن عمه وابن عمته. يعني المشاكل عندنا جسيمه وان شاء الله تتحل، يعني مش عارفه في امتى بس هتتحل.
Amir, how are you? It's good to see you. And all formality of the meeting aside, انت وحشنا وعايزينك تنزل مصر زيارة.
الله يخليك، انا كان نفسي والله ان اكون موجود معاكم يعني ان بيرسون مش اونلاين، لكن ان شاء الله في المرات القادمه باذن الله يعني نقدر نتواجد ان شاء الله مع بعض.
Until we have a question from the floor, I have a question for you. It's a twofold question. How do you see the practice, the guidelines, the ESC guidelines, the recent one that upgraded the role of catheter ablation in patients with ischemic cardiomyopathy and ejection fraction more than 40% without putting in an ICD? And at the same time, how you see that they downgraded the ICD implantation in patients with dilated cardiomyopathy to a class 2A indication? Did either change your practice, and how do you see this in the context of your patient care?
I think these are two excellent questions. Unfortunately, data about the patients with moderately reduced ejection fraction is not good in terms of whether ICD is helpful in this group of patients or not. Secondary prevention studies they said والكاش اللي based عليها كان implantation of ICD in patients with prior cardiac arrest usually does not apply for patients who have a moderately reduced ejection fraction. Quite often, those patients, if they have VTs, they may be hemodynamically stable, so they are not at risk of sudden death because of those hemodynamically stable VTs. But that does not preclude them from having any hemodynamically unstable VTs as well. أنا أعتقد downgrading role of VT ablation in this group was probably based on some expert consensus rather than actual studies. I'm not aware of any randomized study that compared VT ablation versus ICD implantation in this group of patients with a relatively preserved ejection fraction or moderately reduced ejection fraction. كان في centers يمكن في Italy بالذات they're advocating for this, that if you have a successful or non-inducible patient after VT ablation that you may not need to put an ICD in despite having prior MI. لكن ما اعتقدش ان الايفيدنس is there really either. The evidence for ICD is low as well, and the evidence that VT ablation is better or than ICD is probably not there as well. فاعتقد ان هو ده كان based on expert opinion. The second question is about the downgrading the non-ischemic cardiomyopathy to class 2A. أعتقد ده based على a Danish study because the Danish study was overall negative. There is a lot of limitations related to the Danish study. Probably the major one is that those patients, about 60% of those patients have CRT in both groups, in both arms, the ICD and the medical therapy or the conventional therapy arm. وده لوحده, we know that CRT has a survival benefit on its own. فده لوحده ممكن يبقى سبب why there was no difference in mortality between the two arms. لكن in terms of our practice currently ما اعتقدش ان the Danish study changed much in terms of the practice for primary prevention for non-ischemic cardiomyopathy. We still, like patients with reduced ejection fraction less than 35% on optimal medical therapy, we usually offer them an ICD.
سوري دكتور امير، اسمي امنيه كامل، هيد اوف اي بي يونت ان اسوان هارت سنتر. انا بس كنت عايزه اقول كومنت على الاسسمنت بتاع او الاي سي دي في المودريت او مودريت ريديوزد ايجكشن فراكشن. اي ثينك ان كاتيا زيبنفeld كان ليها جود ورك في الفيلد ده، ان هم كانوا هي ليها يعني قصدي ليها رولز معينه عشان اقدر اقول ان انا ما احطش اي سي دي في العيانين دول. ليه علاقه بان يبقى اكسبرت نون انديوسد اني في تي نون انديوسبل، يعني ما فيش اي في تي نقدر نعملها اندكشن اب تو 3 اكس ستيمولس بكريتيريا معينه. وكمان فكره الكنترول اي بي ستادي تتعمل بعد حتى افتر ستوبج اوف انتي اريثميك ميديكيشن عشان نقدر نشوف اذا كانت هي انديوسبل او لا. بس هي قصه اي ثينك ان هي دي ممكن تكون حاجه بروميسنج قوي، عشان الفكره اللي حضرتك كنت بتقولها ان هي فكره ان اتس اباوت مور عن فكره ايجن فراكشن او كده، اتس اباوت سبستريت. قصدي هي فكره ان الى اي مدى السبستريت دي قادره انها بروجريس. اظن بقى ده السؤال محتاجين نجاوب عليه. هل لو السبستريت دي مش قادره دلوقتي ان هي تديفلوب في تي او هيمودايناميك انستيبل في تي، هل هي قادره باي تايم ان هي تبقى سبستريت لي نيولي ديفلوب في تي بعد؟ المفروض ان القاعده بتقول ان هي ده ميبي بروجريسيف ديزيز. بس اي ثينك ان يعني فكره ان وجود سبستريت معينه وان احنا نابولش كل الكلينيكال في او كل الانديوسبل في تي، اي ثينك انها ممكن تكون بروميسنج العين دول بدل ما نتسرع ونحط اي سي دي فيهم اون اورجنت بيزز، او ان هم مش عارفه وجهه نظر حضرتك في ده ايه. بس متهيألي لو هيمودايناميكال ستيبل عيان هيمودايناميكال ستيبل في تي بالذات وكان في جود اوتكمز من الابليشن، اي ثينك in those patients we can a little bit postpone the decision بتاع الاي سي. I think so.
هو زي ما قلت يعني ما فيش evidence قوي within this group of patients، لكن what we know in في الماس study patients who were non-inducible during EP study still had about 12% risk of sudden cardiac death. Mass study involved patients with a reduced ejection fraction below 40%. يعني فهي دي الداتا اللي احنا we have based on the clinical studies اللي عندنا. واحنا بنشوفها يعني non-inducibility at the end of a VT ablation procedure does not mean that those patients will never have any VT in the future.
It's the problem. It's a probabilistic endpoint. You repeat NIPS after 1 week, you get the VT. You repeat it after 1 month, you get VT in a different proportion of patients. That's why I'm not sure that this is a right decision. In the 2019 HRS IHRA guidelines, they were skeptical about this particular indication for catheter ablation and for the fact that we can alleviate the need for ICD based on it. But this was endorsed by the ESC. So the question is, did this change your practice, Amir, the group in Halifax? You
still patients who present with VT with structural heart disease, we still recommend an ICD for them.
دكتور امير، انا احمد رجب. دايما دكتور احمد كان بيقول لك we miss you يعني. With the current medical treatment for non-ischemic cardiomyopathy in presence of scar, the longest time you wait before the ICD? What is the longest time you wait if the function is below 40% or 35%?
So if they are on optimal medical therapy for 3 months and you assess their ejection fraction, if it is 35% or less, then they are a candidate for ICD for primary prevention ICD implantation.
Thank you.
Amir, thank you very much for putting all that effort in this very comprehensive presentation. We appreciate the time that you spent with us, and we're looking forward for future meetings. We're looking forward also to see you physically. Thank you so much.
Thank you. It's really a pleasure and an honor for me to be with you again, and hopefully for more times in the future as well.
Next speaker, Dr. Ahmed Tahir.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you very much, Dr. El-Damaty, for inviting me. خلاص بنخلص ان شاء الله محاضرة خفيفة. I'm very excited about it. لما دكتور ضماطي كلمني عليها it's a new technology, new field. اتمنى ان هي تكون خفيفة وفي نفس الوقت bringing good and hope for all electrophysiologists. هتكلم على ال pulsed field ablation. How does it work? Probably this is not new. Probably new news few years ago, and I have a feeling that most of you have heard about it sometime in the past few years. So, what is pulsed field ablation? It's a mode of energy, new energy. But why do we need it? Now, the current energy we use for ablation is obviously the radio frequency, and I don't know if I have a pointer here. Okay. So I don't have a pointer. Sorry for that. So we're talking about fire and ice, the radio frequency and cryo. Been there for a while. We use them a lot. They produce predictable lesions. Thank you. So great. Use them for a while. We have good experience with them. Produce predictable lesions. Durable. We can say that. With improved technology, we managed to get some reasonably durable lesions, and they've stood the test of time. But on the other hand, especially the radio frequency, they require a long learning curve to produce effective and safe lesions. The procedure duration is definitely an issue, markedly improving in the past few years, but still we're looking to make it shorter, and it is not free of side effects despite all our efforts, and especially collateral damage, whether with radio frequency or with cryoablation. Now, this is where pulsed field ablation comes in place. Now, before we talk, we need to give a quick hint about the structure of cell membrane. And as you all know from basic physiology, it's a phospholipid bilayer formed of hydrophilic heads and hydrophobic tail that's pointing in opposite direction. And what's important for us that this cell membrane is dielectric. It is charged. It has positive and negative charges on both sides, and it has a resting membrane potential of around -90 in the ventricle, predominantly negative charge in the cellular side, predominantly positive side outside. So what does pulsed field ablation do to these membrane? Now, we know from basic study that if we expose these electrically charged cell membrane to an electric field of certain intensity and duration, these alteration in electric field forcibly moves the charges across the cell membrane, and at a certain force and a certain field strength, these charges form holes in the membrane, and the membrane loses its selective permeability. The whole point of cell membrane is to contain the internal structures of the cell and allow only certain molecules to pass across under very specific condition. However, when you make these holes, you lose this selective permeability, and you pretty much allow everything outside to inside the cells and vice versa. Now, when you look at this is an animation showing you the formation of these micropores. The black is the hydrophobic tails, and the red dots are the hydrophobic heads. And you can see once these forms, the extracellular fluid moves freely inside the cells. And this has been validated with electron microscopy as well. These are RBCs viewed under electron microscopy after exposure to strong electric fields. You can see clearly the formation of micropoles that correlates with the strength of electric fields. Now, as I understand, the next lecture will be about radiotherapy. And this is the concept of pulsed field ablation. It is borrowed primarily from oncologists. This is probably new for cardiologists, but it's been there for a while among oncologists. And they used it, and mainly they used the reversible phase. Now, before going into that, this graph shows the relationship between the strength and duration of electric fields and the degree of poration you induce in the cell membrane. At certain area, there is no electroporation at all, and the cells are pretty healthy. And if you increase the strength or duration, little bit, you can reach to the stage of what we call a reversible electroporation, in which there are pores formed in the cell membrane, but they recover spontaneously after a while. However, if you increase the strength of electric fields, you reach the degree of irreversible electroporation, in which the cell cannot survive the extent of poration in the cell membrane, and they start to die. And this is the first interesting thing. When the cell dies by this way, it dies by apoptosis, not by protein denaturation that we see with thermal energy. And this is why the cell death by irreversible electroporation maintains the tissue scaffold. So the extracellular matrix is not affected and remains intact. And of course, if we increase the strength and duration of electric field, we reach to the degree, to the limit of thermal energy. And this is what we currently using with radio frequency. We actually work on that end of the strength field, strength duration curve. And in this area, the cell dies of protein denaturation and the tissue scaffold is damaged, and we get the collateral damage. So we are aiming to this spot here, in which we produce a lesion that is irreversible, but it is not thermal. Now, so far what we talked about, the electroporation, we know that it is non-thermal. We know it uses short pulse duration, limited number of pulses, and it preserves the extracellular matrix. Now, there are many challenges, or at least there had been many challenges to tweak the parameters of pulsed field ablation lesion to produce this irreversible nature without reaching thermal and without landing in the reversible electroporation. And these parameters has many things to do with electric pulses itself, the way we deliver these electric pulses catheter, and the targeted tissue. And we will go briefly through these determinants. Now, I know this is a very busy slide. I intended to put it this way just to give you an impression how far we have come from pulse field ablation point of view. Each parameter in the pulse makes a difference, whether the pulse amplitude, the duration, the interval, the frequency, the polarity, the mode of delivery, all these parameters, even the microparameters of the pulse, itself, they can change the reversibility of the lesion. And this is almost the list of all these parameters. One of them are intuitive, and interestingly, some of these parameters are counterintuitive. For example, if you reduce the frequency of the pulse, you get a more durable lesion. Now, the other determinants of pulse field ablation lesion are the catheter we use to deliver these pulses. It could be delivered in a unipolar fashion between the catheter and grounded electrode, the same setup we use for radio frequency. It is still effective, produces deeper lesion, yes, but comes at the cost of unpredictable lesion edges, boundaries, depth, and it can stimulate nerves and muscle if you use it in this configuration. On the other hand, the bipolar pulse field ablation also produces lesion, but is more predictable, more remote, more delineated, and with less stimulation of nerve and muscles. Other parameters related to other determinants of the lesion is the inter-electrode distance. And the wider the electrode, as you could imagine, the larger and more irreversible the lesion is. Of course, you don't want it to be so wide so that you do not move to the unipolar size of ablation, but inter-electrode distance is also an issue. Catheter orientation and catheter proximity all still are important predictors for the lesion. Now, pulsed field ablation primarily was marketed as non-contact form of energy. Yes, you do not require contact, but you need proximity. You can see here that although the catheter is not touching, there is a field induction in the tissue, but you need to have at least a contact for this field to be as deep as possible. So catheter contact, proximity, or orientation also affects the lesion we produce. The third category of determinant is the tissue, and this is probably why it is not so popular in the ventricle, at least so far. The tissue itself, although it's still a cardiomyocyte, still has the same selectivity as the atrium, but because most of the challenge in the ventricle are related to non-ischemic or to ischemic cardiomyopathy in which there is scar, the water content in the scar is significantly different from the water content of the healthy tissue, and accordingly the impedance of the scar is different from that. And so far, we don't know if this has significant impact on the pulsed field ablation and the durability of lesion, but this is to give you an idea about how the ablation in the ventricle in the scar tissue is different from that in the atrium, and the different ink content and water content between scar and between healthy tissue, and the resultant change in impedance have been studied and validated by MRI studies in human, and it's clearly show content, the water content in scar tissue is significantly larger than that in healthy tissue. So in summary, this is a brief list of all the parameters you need to tweak in order to achieve an irreversible electroporation. It has been a very long journey, very difficult to land in this sweet spot of irreversible non-thermal energy. Good news that most of this work has been done. We have fairly acceptable parameters or recipe for pulsed field ablation, and this has been studied in human using multiple modes by Vivek Reddy, who pioneered, or at least one of the pioneers of this ablation technology. And in 3-month follow-up studies now, with the last configuration of bipolar lesion at almost 2K volts for at least 2 times 2 applications, you get a nearly 96% durable PV isolation of the single PVI of medical treatment. So does it work? Yes, preclinical studies clearly show that when you ablate in animal models, there is a clear demarcation between what is healthy, what is ablated, and what is healthy, and you can appreciate the preservation of blood vessels within the ablated tissue in the wall of the right atrium. Now, in histological studies also prove that delivering a lesion this way produces transmural lesion. As you can see, these are the blue area. This is the transmural scar. And when you look carefully within the lesion, you can see the preservation of blood vessels and nerves as well. So, why is this lecture? Why are we so excited about pulsed field ablation? The first thing is the safety. And this is a conceptual graph. This is not actual data. When we use thermal energy, at certain points, we create a lesion. And at that point, there is no collateral damage. However, shortly above this threshold of tissue injury, we can easily reach the threshold of collateral damage. And this margin is quite narrow for thermal injury. On the other hand, the pulsed field ablation has a fairly wider safety margin. The incidence of reaching or injuring tissues other than the heart is quite low for pulsed field ablation. Why is this safe? Because we know from preclinical and early clinical that there is very high tissue selectivity of pulsed field ablation. Now, the strength of electric field applied using pulsed field ablation is expressed in terms of voltage per centimeter, and these are the threshold for creating an irreversible electroporation in different tissues of the body. And as you can see, the myocardium has a threshold of 400 volts per centimeter, and the nearest cardiac structure, which is the vascular small muscle, has a threshold of 1,700. So if you tweak the parameters correctly, you are very likely to ablate the myocardium only without affecting any collateral structures to the heart. Now, this is not only from preclinical. This is very interesting study from the preclinical phase of the trial. This is a porcine model. The catheter, they compared the lesions formed by radiofrequency catheter on the right and the pulsed field ablation catheter on the left. They placed the catheter in IVC, and this is the esophagus lying just opposite to the IVC. Moreover, they inserted a balloon in the esophagus to push it towards the IVC so that the contact is as close as possible to the catheter. And they used the pulsed field ablation catheter over here, the radio frequency ablation catheter, the level 2 kilovolts of for 8 application in the IVC, and they ablated here for 30 watt, 30 seconds, 7 minutes, and 6 lesion. And 1 month later, they sacrificed the animals and they examined the esophagus and the IVC. As you can see, the IVC here is completely ablated, but the esophagus is completely healthy. However, in the other 4 animals, all of them, all lesions set, there's a big hole in the IVC and the big hole in the esophagus as well, denoting the presence of fistula. And this shows you how specific the pulsed field ablation is for creating lesions. Now, in human, this has also been proven in human studies, ligadonium enhancement in the atrium, comparing pulmonary vein isolation using balloon catheter, radio frequency, and pulse field ablation. And they performed MRI, LGE MRI study of the atrium and the esophagus shortly after ablation. And you can see there is some sort of esophageal enhancement, denoting early affection of the esophagus. We know that this does not necessarily translate into esophageal injury later on, but the point is that despite early ablation on the posterior wall, the pulse field ablation catheter had no impact whatsoever on the esophagus. Okay? Now, why is this attractive? It's not just selectivity. It's not just it only ablates the heart, but the fact that it preserves the extracellular matrix and the structure of the heart makes it also attractive. Important, yes. This is an interesting study in which they studied the left atrial function, the left atrial strain immediately after ablation and 3 months later. And as you can see, this is the MRI before the all veins are connected. MRI immediately after, you can see the enhancement around the pulmonary vein and the isolation. And they brought those patients 3 months later and studied their MRI and voltage as well as left atrial strain. And if you can see here, there is no scar in the MRI study, despite having all veins isolated. And when you look at left atrial strain and you compare it between acute and chronic, it almost returned to the same values as baseline. And this has to do with the preservation of the structure of the left atrium. This also has impact on the risk of pulmonary vein stenosis. Again, MRI studies using pulse field ablation as compared to RF study, to RF ablation, and looking specifically at the pulmonary vein diameter using MRI study. And you can see there is no change at all in the diameter of the pulmonary vein. And you can see here, appreciate some narrowing in the left superior pulmonary vein, again, due to the preservation of the extracellular matrix and the skeleton of the heart. So the good news, all these factors have been integrated, and we currently have a system that utilizes pulsed field ablation. This is one of the first commercially, I'm not sure it's commercially available, but at least integrated in a form that shortly will be commercially available. This is the FARAPulse system. The interface is as simple as that of the cryoablation. Just set the strength, the field strength, and you deliver the catheter, single catheter, over the wire approach, single transeptal puncture. Once you position it in the left superior pulmonary vein, you deliver series of short applications, 2 by 2 in each vein. They call it first basket configuration. 2 applications using basket configuration, which you rotate the catheter slightly between. So this is the first application. And after 2.5 seconds, just 2.5 seconds, you rotate the catheter in this basket configuration. You deliver another 2.5 seconds. Then you change it to this flower configuration, another 2.5 second application, rotation 36 degree, another 2.5 seconds, and 2 by 2 application, and this vein is done. That's it, as simple as that. You can appreciate the selectivity, the cardiomyocyte is damaged, but the blood vessels, nerves, and esophagus are all preserved. And you repeat that for all veins. Again, preservation of the nerves and phrenic nerve is also an important, although there have been reports of transient lasting 6 seconds of nerve injury. However, never lasting nerve injury, never lasting phrenic nerve injury. Now, in real life, this is how it looks. I mean, don't blink, otherwise you will miss the application. So actually, the orange signal is the PV signal, and these are the series of 5 application of pulmonary, and voila, it disappears. Single application, as simple as this. And usually this happens with the first application, and you only deliver the remaining application to ensure the complete isolation and the durability of the lesions. Now, this is the first system to develop the pulse field ablation, the flower, the basket, and it is now being developed or applied on other catheter. The focal catheters, Acutus is the first system, one of the first systems to use pulse field energy on focal ablation catheter. Obviously, it has many potential for linear region for addressing specific area substrate. And there are recently studies about using pulse field ablation for parahesian accessory pathway for simple tachycardia as well. So this has been published and in press. Biosense Webster, I don't know if they are here. They already have their own system in the pipeline called VariPulse. TruePulse. It's also a pulse field ablation system mounted on what I think is a reutilization of their Inmark catheter. So if you're familiar with that, they've brought it back and they are applying the pulse field energy to it. Again, the earlier results of safety and efficacy are very promising. It's not commercially available yet, but I think this is a future we are heading to. So my take-home message is that pulse field ablation produces non-thermal damage of the dielectric cell membrane by high voltage fields. Many fields, catheter, and tissue parameters contribute to the volume and durability of the produced lesion, but however, under optimized parameter, it is safe and effective form of lesion delivery. Thank you very much.
Thank you, Dr. Ahmed, for this wonderful and illustrative lecture. I have 2 questions. First, what is the success rate of pulse field ablation in comparison to RF ablation? And does it have a role in persistent AFib?
Okay. So the first question is actually is an ongoing trial now. This is the Advent trial, and it is recruiting, and this is the first randomized trial to randomize PVI to either pulse field ablation or radio frequency ablation. So this is underway. The success of pulmonary vein isolation acutely is 100%. So from early studies of Vivek Reddy, we know that the problem is not in the acute isolation, the problem is the durability. Okay. And well, it's a bit early. We don't have long-term data, solid long-term data yet. I think there is 1 year success reported, and it is in the same average of the best radio frequency tool. So we're talking about 80, something like that. Bear in mind that pulmonary vein, although are important for life, they are not the only mechanism. So although you can have a complete pulmonary vein isolation, but you can still have AF recurrence. So the best we have so far is around 80. And for persistent, yes, if your only goal to do pulmonary vein isolation for persistent, you can use the basket or flower catheter. But with the development of pulsed field on focal ablation catheter, you can use it for linear lesions as well. And I think Acutus, yes, Acutus has a registry for linear region targeting the roof line, mitral, and the posterior wall isolation with the platform.
Thanks a lot, Dr. Ahmed, for this talk about a new energy source that we hopefully will be using in the near future. Do we have data with the use of this source of energy for VT?
I'm not familiar with. I mean, the Acutus has what I had is Acutus had data on lesions in the ventricle as deep as 17 millimeters. Okay, so this is right. Does this translate into clinical practice? I'm not familiar with it. If you have.
مفيش داتا solid على اليوز بتاعه في الهيومن، بس كان first in human، كان في اكتوبر 2022 دي published. كان حد الكسندر اوس، مش عارفه بنطق صح او لا، ده في نيذرلاند، وعملوا اول حاله ليهم ان في تي ابليشن لاندروسبتال سكار في عيان عامل ريدو. ده كان عمل في تي ابليشن قبل كده توايس، وكان ريزيستنت في تي، ودخلوا وعملوا ابليشن بالباس فيلد ابليشن. هم استخدموا الباس الفلاور شيب، يعني خدوا نفس الاسطوره دي واستخدموا فلاور شيب وادوا 3 ابلكيشنز. وكان الراشونال زي ما حضرتك بتقول ان فكره how to ان احنا we deliver lesion we think in it is more deep than the radio frequency. وده اللي كان confirmed بانيمال ستاديز according to what I know، ان هو الافريج يعني around 6 ملم I think ده اقل دبث ممكن توصل له باس فيلد versus ان هو حوالي 3 ملم بالراديو فريكونسي. That's why كانت الفكره ان لو احنا بنتكلم على حاجه septal and we are suspecting in its deep deeply inside. So ده كان اول حاله اتنشرت في اكتوبر 2022. one case. Okay.
Interestingly, the first use of animal trials, animal experiments with pulse field ablation were in the ventricle, on the ventricular tissue. But when it is used because of its selectivity, it's used in the atrium in human.
I have a question for you, Dr. Ahmed. Do you think in the future, does it have a role for ablation for atrial flutter?
Yes, I'm very excited about it, and I think it will take over the ablation energy. All the companies are now racing to acquire this technology. Now, the application on focal catheter made linear regions possible, and acutists now they have series of patients in which they perform linear regions for flutter, be it true flutter or mitral isthmus flutter. But yes, it is
هم
coming.
استخدموه off label for CTI dependent atrial
Yes.
flutter.
Yes.
إنما how about the atypical atrial flutter?
The challenge with linear lesion is the first basket catheter and flower catheter were developed as a standalone ablation system. So it's somehow like the cryoballoon. You need 3D mapping, you don't need localization. You go, you perform angiography, selective venography of the veins, and you produce the catheter, and voila, that's it. Now the Acutis and the Varipulse and TruePulse system, they are integrated with 3D mapping system. And the beauty about it is that they projected the lesion produced by pulse field ablation on the system. And this is actually the movie I showed about catheter orientation. The lesion you showed here is actually the projection of the field on the 3D model. So yes, you can deliver linear. You will be able to do that, and you will be able to track the lesion within the catheter itself. Okay. Thank you very much.
Speakers, Professor John Camel. His lecture is ablation of mid-septal ventricular arrhythmias.
It's my pleasure ان انا احضر هاي ليفل بي تي كامبس. الحقيقه دي حاجه لطيفه ان انا ابقى موجود هنا ونبتدي نتكلم على هاي ليفل ventricular arrhythmia. My agenda. شغال ازاي؟ My agenda today why septal. ليه هنتكلم على septal ventricular arrhythmia بالذات؟ ليه sometimes difficult to ablate السبتال ventricular arrhythmia؟ التايب سواء idiopathic او scar related، والديفرنت ابروتش اللي احنا بنلجأ لها علشان to tackle septal ventricular arrhythmia. Either anatomical guided approach, simultaneous unipolar ablation and use of low ionic irrigation, bipolar ablation, and lastly needle ablation or heated saline irrigated needle ablation. This is my agenda today. أول سؤال هو اشمعنى السبتال ventricular arrhythmia sometimes difficult to ablate؟ والإجابة سهلة قوي، إن
السبتم have أو septal ventricular arrhythmia usually have intramural extension, intramural exit of tachycardia, even idiopathic type or even scar related. وعلشان كده هي من يعني لو احنا الستاديز قالت ان 30% من السبتال ventricular arrhythmia usually have intramural origin or extension, so it is difficult to ablate. We have two types: idiopathic ventricular arrhythmia. We usually mid-septal ventricular arrhythmia or intramural can be found both idiopathic and scar related. The idiopathic usually arising from RVOT arrhythmia, and interestingly that it is not originating from the myocardium. بالعكس ده هم لقوا ان في حاجات كتيره بتطلع what's called paravascular related للسبتال فين والارتيريال برفريتور، وعشان كده it is difficult to ablate. يعني هو هنا كنا زمان بنفتكر ان الار في او تي ventricular arrhythmia is origin from the myocardium. Okay, وكانت easy to ablate from the ventricular side, either from right ventricular side او the aortic cusp والleft ventricle. لكن الحقيقه هم وجدوا ان a lot of ventricular arrhythmia which originate in the RVOT, it is related to what is called paravascular origin or septal perforator, سواء either veins or arterial perforator. ويمكن الرسمه دي بتاعت الكوروناري ساينس فينس سيستم هنلاحظ في كذا فين related ل الار في او تي والاورتيك كاسب. واحد من الانترستنج فين هم سموه communicating vein اللي بيربط بين الانتيريو كاردياك فين والرايت كاردياك فين، وده ماشي between the aortic cusp ده posteriorly وانتيريور هو للار في او تي مزنوق في الحته دي هي، وده is a site of origin of ventricular arrhythmia. الوصول ليه عاده بيبقى either to ablate from either side، لكن ساعات مهما حاولت ما تعرفش ايه نوصل له either from left or right side. Also idiopathic ventricular arrhythmia الاريزميا كانت origin from البيزال inferior septum، و a lot of theories اتنشرت على what is called البوستر inferior process of LV اللي هي حته موجوده تحت في البيزال part of inferior septum، و it is commonly ال origin of ventricular arrhythmia فيها بيبقى mid myocardium or even epicardium. وبرضه لو احنا بصينا عليها هنلاقيها it is difficult to ablate، لدرجه ان هم احد السيريس اوف ابليشن قالوا ان احنا ممكن even نكويها من الرايت اتريوم علشان نقدر نوصل للبوستروسيبتال بروسيس اوف ال بي. فكل دي why is septal ventricular arrhythmia even idiopathic type it is difficult to ablate لأن it is not arising from the superficial endothelium of the myocardium or endocardium، لا هي deeper inside the myocardium and even paravascular. وإيفن الجزء الثاني scar related ventricular arrhythmia هنلاقي إن جزء كبير مثلا من النون اسكيميك دايليتد كارديوميوباثي اللي بيجي لهم في تي، وجزء كبير منهم اللي هو از لامينوباثي. هي الصوره يمكن منغبشها شويه صح؟ اللامينوباثي هنلاقي ان جزء كبير من البيزل سيبتم have the origin of VT، وأني حته من البيزل سيبتم هنلاقيه even have intramural extension is very common in such dilated cardiomyopathy theories. فاذا الانابلسي عندهم الحته دي، الكاردياك ساركيوزز عندهم الحته دي. دول اكتر اتنين فيهم بيزال افكشن اوف او بيزال سيبتال افكشن اوف ventricular arrhythmia في السكار ريليتد، وغالبا بيبقوا هاف ان intramural isthmuses and intramural extension. وعشان كده هي الحته دي صعبه قوي to ablate such entity in dilated cardiomyopathy. فاذا سواء الايديوباثيك او السكار ريليتد اللي بيطلعوا من السبتم او البيزال سبتم it is difficult to ablate. خلاص احنا عرفنا، فهمنا الاناتومي وفهمنا الايه why difficult to ablate. طيب it is estimated that 10 to 15% of ventricular arrhythmia all over بقى، ده بقى مش سبتال بس، ده كل الفنتريكولار اريزميا عندها انتراميورال اوريجن، وده نسبه كبيره باي ذا واي. يعني انت لو كل 10 عيانين في عيان مش هتعرف تكويه عشان انتراميورال اوريجن، دي حاجه مخيبه للامال. طب ازاي نحسن الريزلت؟ اول حاجه بري بروسيجر ايمجينج، اللي انت تحاول تجيت ان ايمج للعيان ده. يمكن في محاضره الدكتور جون ساب قال ان انتجريشن اوف مايوكارديال ايمجينج مهم لتحضير عيان الفنتريكولار اريزميا سكارليتد ابليشن. نفس الكلام even الكارديك ام ار اي often identify mid myocardium delay enhancement. الحاجات الحلوه اللي الام ار اي بتقدر تعملها لنا ان هي تحدد لنا الميد مايوكارديال ديليت انهانسمنت. انا فاكر دلوقتي يعني الريبورت اللي بتطلع عندنا من الام ار اي الناس بقوا قادرين يحددوا كويس قوي اذا كان ابيكارديوم ولا انترا مايوكارديال ولا اندوكارديال. ودي حاجه لطيفه انا شفت يمكن اخر 3-4 ريبورت من الام ار اي بيقدر يحددوا دي حاجه لطيفه. صحيح ان الديفايس ريليتد ايمجينج ارتفاكت ليميت ام ار اي اكيورسي، بس اتس وورث ان انت تعمل كارديك ام ار اي لمعظم عيانين اللي انت سسبكت سيبتال اريزم. الحاجه الثانيه امتى تو ايدنتيفاي برضه انتراميورال سبستريت او انتراميورال اوريجين، الانتربريتيشن بتاع الباي بولار واليوني بولار فولتج. احنا كلنا عارفين ان احنا بنعتمد على الباي بولار فولتج سواء في اليوث 3 دي مابينج، واليوني بولار عاده بيبقى فوق البيعه كده. لكن لو احنا لما الناس التزموا ان هم دايما يانلايز البايبولار واليونيبولار فولتج كاركترستيك، بيبقوا عارفين كويس العيان ده هيبقى عنده انتراميورال اوريجن او عنده ايبيكارديال اوريجن. فهنا ما ننساش ان احنا نستخدم التو تكنيك البايبولار واليونيبولار فولتج كاركترستيك او مابينج تو دايجنوز الانتراميورال ثرومباي انتراميورال اكزيت. طيب اول حاجه اول approach, the only approach that has been reproducibly demonstrated to allow direct intramural layer recording is by assessing septal coronary arterial or venous tributary. احنا كل ده بنحاول نقول ازاي نقدر نجيب او معلومات اللي احنا نلاقي انتراميورال اكزيت. ف من حوالي 10 سنين او 12 سنه لقينا كل الناس الانترستنج في الفنتريكولار اريزميا يحبوا يكونيوليت الديب كوروناري فينس سيستم، يوصلوا اساطر الكوروناري فينس سيستم لاخر اكستنت هم يقدروا يوصلوها. ليه؟ علشان خاطر ان احنا اتفقنا ان في الوت اوف فنتريكولار اريزميا طالعه من الانتراميورال بريفاسكولار، فالحاجه الاكيد اللي احنا نقدر نطلع منها داتا كانتراميورال سيجنال هي الايه؟ الكوروناري ارتريال وفينس تريبيوتري. فعشان كده اليوز اوف سمول 5 ملم or even 4 ملم دي كابولار كاثيتر اقدر اوصلها للانتيريو كاردياك فين او السبتال بالفريتور، دي حاجه كويسه، دي اقدر اجيب منها سجن. يمكن هنا في in such patient لما اتحط ديكابورر كاثيتر ودي 4 or 5 ملم inside one of the septal perforator، قدر يقول ان السيجنال فعلا سابقه الكيورس كومبلكس ب 44 ملي سكند. لو احنا شفنا الفولتج ماب ولا سوري الاكتيفيشن ماب، هنلاقي ولا الار في او تي ولا ال في او تي قدروا يجيب such point. والابليشن هنا ما تمش او ما كانش سكسسفول الا from inside this coronary venous system. فدي من الحاجات المهمه اللي احنا دايما اللي بيستخدموا الفي تي ابليشن او ايفن فنتريكولار ابليشن، ان احنا نوصل للديب انترا او سيبتال برفوريتور. طيب مش يعني وات ايفر ما عرفناش نوصل او نكوي او اكزit البوينت اللي احنا عارفين نوصل لها، او ايفن وانت بتحاول تكوي جوه السيبتال برفوريتور القسطره حاجه من الاثنين هتواجهك، يا اما الامبيدنس هتبقى عاليه قوي وبالتالي السيستم مش هيعرف يدي، او هيبقى في انجري للايه للاناتوميكال اللاند مارك بتاعتنا اللي هي مين للكورونري ارتري. عشان كده اي حد بيكوي جوه الكورونري ساينس هم عاملين ليميتيشن انت ما تزودش الوات عن 20 او 25 وات، واللي انت لازم تصور الكورونري اناتومي الارتيريال كورونري اناتومي، عشان لو انت قريب باي 5 ملم لاي ايفن branch even the ramus artery you should abort البروسيجر بتاعك. فعشان كده اول ابروتش اخترعوه لو انت مش عارف تكوي بالظبط الانتراميورال اوريجين هو واتس كولد اناتوميكال جايدد ابروتش، وهو سمبلستي بتاعته ان هو بتحاول توصل لاناتوميكال لاند مارك قريبه للاكزيت بتاع الفنتريكولار اريزميا از soon يعني على قد ما تقدر. ف الاناتوميكال جايدد ابروتش صحيح الكلينيكال ستادي evaluating the benefit of this anatomical approach using conventional radio frequency هي بتقول ان هي optimum result about success 25%، ولكن 25% ان كل 4 حالات هتستخدمهم الاناتوميكال جايدد ابروتش هتعرف تنجح اللي انت تكوي such arrhythmia دي لوحديها benefit. ف this patient is a couple of weeks ago I operate with Dr. Hayam. It was 40 years old male with hypertrophic cardiomyopathy, non-obstructive, with frequent BVCs. These BVCs was even high burden, about 20-25, with non-sustained VT. وكان الكلام هنا بقى ده hypertrophic cardiomyopathy هندخله نركب له اي سي دي لان هو بالكرايتيريا نون سستين في تي، ولا نحاول تو تاكل ساتش بي في سيز والفي تي. فالمهم احنا دخلنا قلنا هنحاول الاول نعمل له الفي تي ابليشن، ما احنا عارفين ان هو الصعوبه بتاعته. واول حاجه عملناها اللي احنا الكورونري ساينس، لو انتوا باصين ده في ال ابروتش كورونري ساينس وايفن دي كانت 7 برانش بايوسنس كاثيتر، بس قدرنا نوصل للانتيرو كاردياك فين. شايفين يعني ده هنا الجري كاردياك فين، ولما بنكمل تحت الانتيرو كاردياك فين. والانترستنج سيجنال اللي خدناها من هنا ان احنا سابقين الكيو ار اس كومبلكس ب 42 ملي سكند فروم ساتش بوينت. اوكي، فدي اول حاجه احنا خلاص عرفنا ان احنا بنتعامل مع intramural origin of ventricular arrhythmia. طيب لما جينا ندخل الابليشن كاثيتر، احنا قبل ما ندخل الابليشن كاثيتر قلنا هنعمل ار في ماب ونشوف اذا كان قادرين نجيب حاجه قبل ال 42 ملي سكند ولا لا. unfortunately الار في ماب اقصى حاجه جبناها كانت 25 ملي سكند من الايه السبتال ايه سايد او البوستيريور سبتال سايد. فديفينتلي قلنا هنحاول نكوي جوه الكورونري ساينس، لكن unfortunately الهاي امبيدنس في الحته دي ما عرفناش نكوي. ده مش بس كده، ان كان في اناتوميكال الريمس برانش كان موجود هنا فما عرفناش نكوي. طب قلنا خلاص اناتوميكال جايدد ابروتش هنحاول نكويها ايفن من الار في او تي، مع ان احنا عارفين ان الاوريجن مش في الار في او تي، بس ده الايه الاقرب حته للانتيريور كاردياك فين. مالتيبل تراي في الار في او تي ما عرفناش نكوي. a lot of تراير فيه، مع ان هي it seems a very good map، لكن ما عرفناش نكوي. طيب هنعمل ايه؟ فدخلنا ليفت سايد، واحنا متاكدين ان الليفت سايد هيبقى غالبا متاخر، فعملنا الليفت سايد ماب. وكنا انترستنج، دخلنا الاورتيك كاسب، ده الليفت كرونري كاسب، وده الاورتيك كاسب، وده الكوميشن. الماب لوحده يقول لنا ان الكوميشن هو الايرلي سايد، بس combined with the RVOT definitely it is later than the RVOT. الفين او الانترميورال اورجن جاي من الحته دي. طيب كان الفكره، طب احنا ما عرفناش نكويه ولا من جوه الفين ولا من الار في او تي، واي تو تاكل، ليه ما نقدرش نحاول نقرب للكوميشر ونحاول اناتوميكال جايد ابروتش؟ والحقيقه لما دخلنا كده، وده كان ليت سيجنال ان احنا يعني كنا مش سابقين حتى ب 10 ملي سكند. ده المكان الوحيد اللي هو بعد 3 سكند اوف ابليشن قدرنا تو اليمينيت such BVCs. ولو احنا شايفين الصوره، احنا حاولنا كتير في الار بي او تي، just 2 point or 3 point of ablation بعد 3 سكند eliminate definitely the BVCs. This is called what is called anatomical guided approach. بتحاول توصل لمكان anatomical قريب للانترميورال origin of ventricular arrhythmia. طيب sometime you cannot، ما تقدرش، بتعمل اللي عليك بس ما تقدرش. هل في حاجه تانية نقدر نعملها؟ yes. simultaneous unipolar ablation محتاجه 2RF generator، مش موجوده في كل الاي بي لاب، لكن معظم الاي بي لاب الكبيره هيبقى عندها 2RF generator، وهتدخل قسطرتين والاثنين اكتف ابليشن، يعني اثنين اكتف ابليشن. واحده مثلا في الحاله بتاعتنا دي حاجه مشابهه، ان انت هتدخلها واحده في مثلا اورتيك كوميشر وواحده في الار في او تي، وتعمل سيمالتينيوس ابليشن. طب وهو النظريه بتاعته ان هو هيعمل لك مور ديب ليجن لو انت عملت سيمالتينيوس يونيبولار ابليشن. اوكي، ف سيفتي ات از سيف. ليه؟ لان انت بتجايد، انت جايدد باي تمبريتشر، جايدد باي امبيدنس، جايدد باي كل حاجه، بس بتستخدم قسطرتين في نفس الوقت. فsimultaneous unipolar ablation it is a safe ablation. Okay, and they have a deeper lesion than sequential unipolar ablation. فده تاني حاجه كنا هنستخدمها لو الاناتوميكال جايدد ابروتش ما عرفناش نعمله. وهنا فكروا في what is called bipolar ablation، ويمكن هما ناس كتيره دلوقتي بيعملوا البايبولار ابليشن لريفراكتوري فنتريكولار اريزميا either idiopathic or even scar related. والفكره كلها في البايبولار ابليشن اللي ما سمعش عنه، ان احنا في اليونيبولار ابليشن في اكتف ابليشن، والريتيرن الكترود هو ده الريفرنس باتش او الباتش بتاعت العيان. فاللي بيحصل dispersion of الار اف من عند الميوكارديوم، وديسبيرد لغايه ما يطلع من الايه الريتيرن الكترود اللي هو الباتش الموجوده في ظهر العيان. طب لو احنا حطينا 2 كاثيتر اكروس ذا سيبتم، وحطينا واحده اكتف الكترود او واحده اكتف ابليشن والثانيه ريتيرن الكترود، بالتالي ده هيعمل كونسنتريشن، هيركز الار اف جوه السبتم. فدي كانت الفكره ان هم يستخدموا البايبولار ابليشن اكروس ذا سبتم، وبعد كده استخدموها اكروس ايفن ذا هول مايوكارديوم اندو ايبي. يعني الوقت البايبولار ابليشن ايفن بيستخدم مش بس في السبتال فنتريكولار اريزميا، لا بيستخدم كمان في الايه كومبايند اندو ايبي ابليشن. طيب الفكره بتاعتها اللي انا بلغي الجراوند الكترود وبحوله ل ريتيرن الكترود في الكاثيتر. ودي المنظر بتاع البيوبسي اللي شايفين فيها ده، بس ده كان ايبيكارديال ابليشن. شايفين بيبقى يا دوبك عامل مثلا بنتريشن ل 4 أو 5 ملم، وده البايبولار ابليشن هاوتس ديب، وواخد كل الترانس ميورال مايوكارديوم يز، وبيبقى الاكزيت بتاعه سمول والانلت بتاعه سمول. خلي بالنا البايبولار ابليشن غالبا انلت واكزيت سمول، فهو بينفع جدا في الانتراميورال اوريجين اوف ventricular arrhythmia. يمكن مالتيبل كيس ريبورت اتعملت في ال3 سنين اللي فاتوا ان هم ازاي يستخدموا البايبولار ابليشن في الديفيكالت سيبتال اريزميا، وكان ناس كتيره بتستخدم تعمل بايبولار ابليشن بتوين الكوروناري فينوس سيستم از ريتيرن الكترود، يعني بيحطوا قسطره غالبا الابليشن وبتبقى غالبا 8 ملم، ويمكن هنقولها ليه 8 ملم في الكوروناري فينوس سيستم كريتيرن الكترود، ويعملوا ابليشن سواء من الار في او تي او من الايه الاورتيك كاسب او ال في او تي كاكتيف ابليشن. كل ده علشان فور ديفيكالت سيبتال اريزم. طب ايه الكونسيرن بتاعته؟ ايه مشكلته؟ ان لو حطينا ار اف جنريتور واحد بس، فاحنا وي ويل مونيتور الامبيدنس بتاعت قسطره واحده. طب الريكوردنج او اللي بنسميها الريتيرن كاثيتر هقدر اشوف الامبيدنس والتمبريتشر بتاعتها ازاي؟ فعشان كده بيستخدموا 2 ار اف جنريتور برضه، بريفيرابل 2 ار اف جنريتور علشان تو تاكل الامبيدنس والتمبريتشر بتاعت الريتيرن كاثيتر. الحاجه الثانيه ان الوات المستخدم لازم يبقى قليل، ما ينفعش ان انا اطلع ب 50 و60 واط، لان الانجري او الانجري اللي بتحصل من البايبولار ابليشن عنيف. عشان كده الكولاترال دامج از ا كونسيرن. سهل قوي اللي انت تعور كورونري، سهل قوي اللي انت تعمل هارت بلوك في العيانين البايبولار ابليشن. فعشان كده هم معظم الاستاديز ما اتعملتش على عيانين دي نوفو، لا هم فيلد مره ومرتين كونفنشنال ابليشن العادي اليونيبولر، وجربوهم البايبولار عشان السيفتي كونسيرن. اوكي، كمان الستيم بوب والستيم كافيتيشن برضه is a major complication في العيانين البايبولار ابليشن. لو ايونيك irrigation ablation، ودي فكره سهله قوي، ان النورمال سلاين used for irrigation هو conduct an electrical current with low impedance، يعني هو بياخد الار اف ويعمل لها dispersion لان هو low impedance which result in RF energy being preferably dispersed away from the high impedance interface between the target tissue and the ablation electrode. طب احنا لو استخدمنا irrigant عنده high impedance، ده هيوجه الار اف اكتر للايه الانترفيس، وبالتالي استخدام الهاف نورمال سلاين create a larger ablation compared to الايه النورمال سلاين. ويمكن قريت كذا بيبر ان هم لما عملوا ميتا اناليسيز لغايه دلوقتي مش لاقيين فرق جوهري. في بعض الناس مؤيده جدا للموضوع ده، وبعض الناس تقول لك لا it does not matter، لكن it is still worthy ان انت تجرب اللو ايونيك irrigation في الحالات الصعبه بتاعه الابليشن. وممكن ايفن تستخدم النون ايونيك ديكستروز لنفس الغرض بدل الهاف نورمال سلاين. واخر حاجه يمكن هتكلم عليها هو الكونسبت بتاع النيدل ابليشن. ويمكن زي ما كانت قالت في اول محاضره النيدل ابليشن هي من زمان اتعملت، وكانت اساسها استخدموا النيدل عشان ياخدوا مايوكارديال بايوبسي، استخدموا القسطره دي وحولوها ان هم يديليفر ذا ابليشن. يمكن دي بتاعه بايوسنس، وكانت عباره عن ريتراكتابل نيدل موجوده على القسطره بتاعه السيرموكول بتاعتهم، ويونيد بتوصل بيه irrigation للرينج ذات نفسه او الدوم، وإيريجيشن اللي جوه النيدل. وفكرتها ان احنا ندليفر الابليشن inside the myocardium. وبرضه كل الستادز اللي اتعملت عليها ما اتعملتش على دينيفو ventricular ablation، لا دي اتعملت العيانين فيل مالتيبل تايم. ولغايه دلوقتي انا ما قريتش سيريس اوف كيسز اتعملت للايديوباثيك في تي. كل الحالات اتعملت للسكار ريليتد في تي، لان هي لتستحق الايه الترايل. وزي ما اعتقد الدكتوره ميرفت كانت قالت ان هي it is not FDA approved لغايه دلوقتي. وبعدين بعد شويه قال لك طب ما نحسن الموضوع ان احنا نعملها هيتد سلاين انهانسد ار اف، يعني بدل ما ندليفر بس ثيرمال انجي او ار اف من النيدل، كمان نساعدها بيه اللي احنا هيتد سلاين انهانسد نيدل ابليشن. كل دي التمبريتشر اللي هم بيودوها للسلاين من حوالي 40 60 سي سي، والسلاين ريت بيبقى من 5 لملي بير مينيت. والسؤال اللي هنسأل هو ينفع ان احنا واحنا بنعمل ابليشن نحط سلاين جوه الانترا مايوكارديوم؟ يس اتس سيف وما بيعملش مشكله وما بيعملش كومبليكيشن. وادي باختصار الورك فلو اللي هو الانيشال سبستريت اور في تي وذ ستاندرد مالتي الكترود كاثيتر اكستشينجد فور نيدل كاثيتر. اوكي لما بيفيل، وبعد كده الاندوكارديال سايت اوفرلاينج ذا بوتنشال في تي سبستريت ايدنتيفايد، هنحط النيدل انسرتد فور ريكوردنج اند بيسنج. النيدل بتاعتنا بتريكورد اند تو بيس. ازاي بنتاكد ان هي بربنديكولار على الميوكارديوم؟ عن طريق حاجتين، اللي انا بحقن جواها صبغه زي ما احنا شايفين بتلون الميوكارديوم، او استخدم الانتركاردياك ايكوكارديوجرافي الايس. ومعظم البيبر كاتبه ان هم في حالات النيدل ابليشن استخدموا الايس فيها. بعد كده قلنا سلاين كونتراست انجكشن فور تيشو ستيننج، بعدين سلاين انفيوجن ار اف ابليشن لغايه 60 سي سي، بعدين بوز irrigation وري اسيس نيدل بيسنج، يعملوا بيسنج بعديها بعد الابليشن يتاكدوا ان هي did not capture the myocardium اذا it is dead myocardium. اوكي ده what is called needle ablation. ويمكن دي الفكره بتاعت البايوبسي ان هي برضه يمكن قريبه للبايبورال ابليشن، هي واخده ترانس ميوراليتي، بس يمكن البايبورال بيبقى بتوصل للانلت والاكزيت على السيرفيس. هنا اكشلي النيدل اتس بيور انتراميورال، اتس بيور انتراميورال. وكان في كيس ريبورت موجوده من قريب ان هم في الفي تي ابليشن بعد ما فيلد مرتين باليوجوال ار اف ابليشن واستخدموا نيدل ابليشن قدروا يكوها، بس بعد شويه الاكزيت اتغير انتراميورال ل ايبيكارديا، فاضطروا يستخدموا الايه اليوني بورال ابليشن عادي عشان يتاكل الابيكارديوم. يعني هي لازم يبقى عندك كل الايه كل الفاسيلتي. مش هطول عليكم اكتر من كده. الكونسيرن اباوت النيدل ابليشن هي نفس الكلام، الانكريز ريسك اوف برفوريشن انتراميورال دايسكشن تمبونات الورثنج فنتريكولار فانكشن. دي نقطه مهمه ان 50% من البيشنت ejection fraction dropped by about 5%، لان احنا هم استخدموها العيانين السكارليتد في تي. هارت بلوك والسبتال ابليشن كل دي concern of needle ablation. And thank you.
شكرا دكتور جون على المحاضرة الرائعة دي. سؤالي لحضرتك، هل في داتا على الالكحول ابليشن زي الفين اوف مارشال للحاجات الديب؟
يس ديفينتلي اللي هو السبتال فين او سبتال فين ابليشن عليها كيس ريبورت لكن مش سيريس اوف كيسز، والمشكله بتاعتها هي برضو السيفتي. ف احد الحاجات المطروحه في التوتاكل difficult septal arrhythmia، وهي septal لكن يمكن ما تقدرش تستخدمها في الهيوج مايوكارديال بقى. يعني انت لو عندك انتراميورال ابيكال او مثلا بيزل سبتال انفيريور بيزل سبتم مش هتلاقي تريبيوتري تقدر تحقن فيه. هو يمكن الكم كيس اللي اتعملوا للعيانين اللي عندهم ال في سمت او بيزل سبستريت بيزل سبتال سبستريت في الدايليتيك كارنيوباثي، لكن غير كده ما فيش حاجه بالظبط.
Dr. John, thank you so much for the comprehensive talk. I think being a conservative ablationist as myself, what I would include in my practice for deep lesions in the near future is using low ionic saline when I suspect a deep focus, and perhaps having a backup another ablator to do unipolar pacing using two ablation systems. I like to be in control. I like to see temperature. I like to see impedance. So this is what I would go for before going to aggressive or perhaps unavailable technologies such as a needle or using bipolar ablation between two catheters while I'm blinded to the other catheter and perhaps need for a specific cabling system and some engineering that I'm not aware of.
مش بس كده، ده انت برضو في البايبولار ابليشن still you have a high impedance، يعني ما بنوصلش للامبيدنس العاديه اللي هي مثلا لما 150 او 170 بتاعه الميد الفنتريكولار اريزميا. انا جربتها في عيان الامبيدنس في احسن احوالها كانت 230 240، اللي هو برضو ستيل الابليشن مش هيقدر يكفي. يمكن مع advancement of the cable ممكن نوصل للامبيدنس العاديه، بس حكايه اللي احنا نبقى مش شايفين الكاثيتر الثانيه هم ابتدوا يحلوها ان هم برضو يستخدموا 2 ار اف جنريتور، واحده للاكتف وواحده للتيرن الكترود عشان تمونيتور امبيدنس وتمبريتشر اوف بوث كاثيتر. بس هم لازم يبقوا الاثنين ابليشن كاست، واحده اكتف كاثيتر وواحده ريتيرن كاثيتر. اوكي ثانك يو.
ازاي عايز اتخيلها؟ واحده هتتوصل بالابليشن بورت جنريتور، الثانيه هتتوصل على الارض بتاع الجنريتور الثاني.
بتتقسم، واحده تخش على الارض بتاعت نفس الجنريتور الاولاني، وواحده تمونيتور على الجنريتور الثاني بكيبل زي تي كيبل كده، تخش على الار اف جنريتور الثاني تمونيتور ذا تمبريتشر اند ذا امبيدنس ويوصلوها تاني. يعني هي ليها تعقيده شويه في الكيبل بتاعها، بس هم بيحطوها هي ليها تي كيبل بيقسمها تخش على الجنريتور واحد وعلى الثاني نفس الكلام. انا ما شفتهاش بس هي ما قريه. انا جربت بس البايبولر على ار اف جنريتور واحد، وزي ما الدكتور احمد الدماطي قال مش قادر اشوف الامبيدنس بتاعت الايه ريتيرن الكترود، مش قادر اشوف التمبريتشر، وكنت خايف وما استخدمش اكتر من 20 واط.
كنت هسأل حضرتك عشان كده اتحط ريتيرن الكترود كبير شويه 8 مللي عشان يعمل ديسبرشن.
هم عملوا كده في بعض السيريز بس، وحاولت اجربها برضه ما قدرتش يعني اكتر من 20 واط ما قدرتش، لان خفت ان يحصل كومبليكيشن.
ما ده السؤال كنت هسأله، يعني الليميت هنا 20 واط مثلا.
20 واط
يمكن
في
اقل
بعض
كمان.
الناس، في بعض السيريز وصلوا لغايه 35 واط. اوكي، لكن فور مي 20 واط لغايه ما الموضوع يتطور اكتر ويبقى ليه سيستم واضح وصريح، لان هو كل الموضوع ده اجتهادات من الناس. لغايه ما يبقى الموضوع ليه سيستم واضح وصريح نقدر نقول هنستخدم 20 واط 30 واط الكيبل كذا الكيبل كذا. شكرا جزيلا.
Okay, by the talk of Dr. John, will conclude our session. It was a very excellent session and very rewarding scientifically. Thank you.
انا بشكركم جميعا. احنا يعني زميلنا دكتور حسين متولي من اسم الراديو ثيرابي جامعه الفيوم كان هيشاركني في اخر توك، وكان هيقول لنا جزء مهم عن الفيزيكس بتاعت الراديو ثيرابي، وبالتالي احنا هنبني عليه الابلكيشن في البي تي. بس حصل ظرف يعني خلاه يعتذر لاست دايز يعني، فاحنا بنعتذر لكم عن التوك دي، وخصوصا ان احنا we had some extensive discussions خلتنا نوصل للأون تايم يعني سكيدول بتاعنا. فأنا بشكركم على وجود حضراتكم كلكم لحد آخر وقت. أنا بيرسونالي استفدت من الجزء المهم الأولاني للهدف من الفي تي كامب، وهو الاكسشينج اوف نوليدج. أنا سمعت الابروتش بتاعت معظم الناس اللي بيشتغلوا في الفيلد، و it really added to my knowledge. الحاجة الثانية I hope إن احنا نكون transferred the knowledge to people here in the room and people who are hearing us online. واخيرا نكون inspired some of the younger generation ان ده يبقى الكارير بتاعهم عشان يتيك اوفر we incorporate more and more advances in the field to the Egyptian patients. Thank you for your presence. I'm happy to have been with you the last 2 days. Thank you so much.